Good afternoon. I do have six, not everybody's in the room. But thank you all. This is the Senate Finance Committee. Thank you for joining us. Today is Thursday, February 8th. We will hear 10 bills today. I'm going to read the bill order. Senate Bill 466, Senate Bill 213, Senate Bill 226, Senate Bill 211, Senate Bill 244, Senate Bill 76, Senate Bill 201, Senate Bill 59, Senate Bill 197, and Senate Bill 98. And I'm going to go to the table on the first bill, and my vice chair will be running the meeting. Thank you all for being here.
Senator Bidle, Chairwoman, do you have your panel? Would they like to come up?
I do have a panel and they would like to come up. Mr.
Okay.
Gonzalez.
And this is
Mr. Wamsley.
Senate Bill 466, Wage and Hour Law, Minor League Baseball Players Exemption. So take it away.
Thank you, Vice Chair Klassmeyer and distinguished members of the Finance Committee. Thank you for hearing Senate Bill 466, which is a wage and hour law for minor league baseball players. This is an exemption. The bill would codify that a minor league baseball player who is part of the minor league players union is exempt from wage and hour laws, just like other salary employees in the state. On March 29, 2023, MLB and the Major League Baseball Players Association agreed to the first ever collective bargaining agreement between the 30 MLB clubs and the minor league players. This bill celebrates a weekly salary for minor league players, highly subsidized health benefits, retirement benefits, housing benefits, club provided meals, per diems on the road, salary continuation for disability that resulting from work-related injury, tuition assistance, and other benefits that we would readily associate with other salaried employees in our great state. Minor league ball players are not the kind of employee who is contemplated by our wage and hour laws. They don't work shifts. They don't have regular hours. We are not staking out new ground. We are in concert with federal law as well as other states whose labor laws reflect the federal law. Moreover, legislation is already passed in California, Florida, North Carolina, and bills are now pending in Washington State, Arizona, and New York. Included in my testimony today is a signed letter from the Players Union expressing support for this legislation. I respectfully request a favorable report on Senate Bill 466. And if I can turn it over to my panel, Madam Vice Chair.
State your name and
Madam Vice Chair, for the record, my name is Keith Wamsley. I'm here today on behalf of Major League Baseball, and the committee will be thrilled to know that my only other task other than urging a favorable report is to introduce you to my friend Steve Gonzalez, who's here from Major League Baseball. He'll be offering testimony and will act as a subject matter expert should there be any technical questions. I urge a favorable report. Thank you.
Thank you. Vice Chair Klassmeyer and distinguished members of the Finance Committee, it's my pleasure to come before you and offer testimony in favor of Senate Bill 466, Wage and Hour Law, Minor League Baseball Players Exemption. My name is Steve Gonzalez, and I'm the Senior Vice President and Chief Employment Counsel for Major League Baseball. In addition to the Chair's comments, there are a few points I'd like to emphasize today. First, to be clear, we're here not because our collective bargaining agreement for minor league players fails to meet state standards, but because both MLB and the players' own union believe that our negotiated compensation structure is most beneficial to the players. Unlike a typical hourly worker, players sought and received part of their compensation in the form of housing, meals, and even signing bonuses. Players also compete vigorously at and away from the ballpark to reach their dream of being called up to the majors, so it doesn't benefit them to have their playing or practice time limited or access to club facilities or resources restricted due to having hourly worker status. Moreover, the party CBA here ensures that players achieve the standard of living intended by Maryland law anyway, as their minimum in-season salary alone would cover them for 56 to 66 hours per week, depending on the player's level in 2024, but does so while recognizing that the experience of a player is unique compared to hourly workers who can only work at employer-specified times. In other words, this bill recognizes that players should be treated as salaried workers who may perform certain job-related activities for their own benefit and development, even if those activities are not required by the employer. For example, on top of the real problems identified by the chair, treating players as hourly workers creates the additional conundrum of determining what hours should even be counted, because players do things on their own time and at home during the season and off season for physical fitness, studying their craft, or otherwise seeking a competitive edge. This is one reason why players are now uniquely paid and receive health coverage year-round, even though their required baseball playing activities are only seasonal. In conclusion, players put in whatever work they deem necessary to achieve their goal of making it to the next level, and this practical bill allows them to preserve that opportunity, and therefore I urge a favorable report on Senate Bill 466. Thank you.
Good job.
Okay, thank you. And questions, and I see one question right here, Senator Kramer.
Thank you, Madam Chair, and thank you for this good bill. And the only thing that came to my mind was go O's. Thank you.
Their trajectory is definitely looking up.
Any other questions? With that, that ends
Hearing.
Senate Bill 466, and we'll
Thank you.
have the chair back up here in her chair. Thank you very much for coming.
Thank you.
Next is Senate Bill 213, Human Services Food Supplement Program, Summer SNAP for Children. Mr. Secretary, do you have anyone on a panel that you'd like to bring up with you?
Just me at the moment, and I have a
Okay.
team to back me up if I mess up.
Thank you.
Good afternoon, Chair Beidel, Vice Chairwoman Klausmeyer, and members of the Finance Committee. My name is Rafael Lopez, and I serve as the Secretary of the Department of Human Services. We respectfully request your favorable report of SB 213. We have submitted amendments to this departmental bill to Committee Council, and you should have those in front of you. We are driven by 12 core values that represent the Moore Miller administration values. And among these are moving urgently, being data-driven and heart-led, and being innovative. And these three values underscore how we approached SB 213. With your partnership, 500,000 children in Maryland will be fed every summer when they're not in school. We hope to leverage $69 million in federal funds per year to do it, no longer leaving federal dollars on the table for which Marylanders are eligible. Together, we will help families feed their children in every single jurisdiction across Maryland beginning in June of this year. When the state summer SNAP program launched in 2013, we served 3,923 children in 4 jurisdictions. Last summer, we served 90,571 children in 14 jurisdictions. The reason not all jurisdictions opted in to Summer SNAP is due to the lack of funds and barriers in the opt-in process. By innovatively and seamlessly building upon Maryland's existing state Summer SNAP program and implementing the federal Summer EBT program, we will help feed 500,000 children across Maryland in every single one of its 24 jurisdictions. DHS is currently required by state law to distribute summer food benefits on a different schedule than the disbursement of federal funds. This doesn't make sense, as we try to make things simple and seamless for the children and families in whose names we serve. It shouldn't be the burden of Marylanders to navigate government bureaucracy to figure out how to get the help they need. It's on us to make it simple and seamless. Our proposed amendments are necessary to integrate the state Summer SNAP program with the federal Summer EBT program, which will enable us to feed 500,000 children. We will provide benefits to all children eligible for free and price-reduced school meals, including those not currently enrolled in SNAP. Based on our work issuing PEBT benefits, approximately 60% of the children receiving school meals are not enrolled in SNAP. Federal funds will cover all of the costs of food benefits and half of Maryland's administrative costs. By investing $9 million in state general funds for our share of program administration, Maryland will receive from the federal government $9 million for administrative costs and $60 million for food benefits. Governor Moore's proposed budget includes a $78 million total investment in the children and families of Maryland for this purpose. Responsibly investing $9 million to get $69 million innovatively leverages benefits for which Marylanders are eligible. We are fully aware that ending childhood poverty in Maryland does not and will not happen overnight. The structural challenges that have plagued Maryland for years are real, and that shouldn't stop us from seeking creative solutions to make sure every single lever we pull helps us make sure children and families get connected to the resources they need to thrive. We respectfully request your favorable consideration of this bill and our amendments. We thank you for your time and consideration, and I'm happy to answer any of your questions.
Mr. Secretary, I have a question.
Certainly.
How will the meals be delivered or distributed?
Sir, we have a statewide series of partnerships across the state. So our department won't actually be delivering the meals. It's
Mhm.
part of an ongoing investment built on an existing program. So this goes back to 2019. Maryland was a national leader in doing this. We have partnerships with the Maryland State Department of Education and a series of organizations across the state, and we will build on that existing infrastructure.
So it'll really be up to the school systems.
It's a partnership. It very much is. We've been working with the interim superintendent, Wright, to figure this out. One of the things about this that's both fun and challenging is that the federal rules came out like December 29th of 2023. So this is very much building the plane and flying at the same time. But the good news is Maryland has some existing experience based on the 2019 passage by the legislature of this. So we'll again build on an existing infrastructure to do this as quickly and seamlessly as possible.
Thank you, Mr. Secretary. We have another question from Senator Ellis.
Certainly.
Yeah, thank you, Madam Chair, and thank you for your testimony, Mr. Secretary.
Sure.
So I'm following you, trying to follow you really closely.
Mhm.
You went kind of fast.
Okay.
And so if you could,
Sure.
I know SNAP, okay, but you threw out another acronym.
Mhm.
It's like is a BET or PET benefit?
Sure.
Which
So
one
we
was
were referencing, thank you, Senator, the pandemic EBT benefits. And
Okay,
what we were trying to
okay.
reference there, sir, was the experience of the department to better understand who is currently on benefits and who is not.
Mhm.
And we're using that experience in Maryland to better estimate how we can serve more children.
Okay.
So that's the reference.
So is that those funds expire or they're still around or just using to see who?
No, those were pandemic related. Those are federal funding that we will no longer have.
So when do those funds expire, you know?
Actually don't know when they expired, but I can get back to you on that.
Okay, if you could.
Sure,
yeah,
happy to.
yeah, thank you,
Sure.
appreciate that. Yeah. Thank you, Madam
Thank you,
Chair.
Senator. And Senator Mouts.
Thank you, Madam Chair. I was checking in the computer did you submit written testimony or your testimony is all oral?
It's written.
Okay, I couldn't find it in the computer. Maybe I missed it. I'll go back and check. And I was trying to follow up the funding for this. What was the funding the last couple of years for this?
Sure. When Maryland launched the program in 2019, it was state general fund dollars, mostly. And this one actually is a combination of state and federal dollars.
Right, but what was the amount of funding?
Oh, it was $4 million.
$4 million, and Governor Moore's increased it to $9 million.
Correct.
Okay,
Or not increase it by additional 5 million.
they increased it, right, increased it by.
So the total is 9. So the federal rules are saying that 30% of the total cost of the program is what we're calling administrative costs. And so that's how we calculate it. So it's a formula that we're actually subscribing to. And the idea here is using existing state general fund dollars that have been repurposed for the investment in operating the program.
And the fiscal note mentions that there's altering the information participating counties must submit on program applications. Do you know what that would be?
I'm sorry, can you repeat the question?
It says that it's altering the information participating counties must submit on program applications. Does that ring a bell?
I'll have to get back to you on that, only because one of the things that we're doing is building it on an existing program. So there were 14 jurisdictions who actually participated in the Maryland Summer SNAP program. So I'm assuming that's what it's referenced to, but I can get back to you on that as well.
Okay,
Certainly.
thank you.
Can I also make one clarification to Senator Ellis's question related to the structure, the way in which the federal government is structuring the delivery of the dollars. So the best way to think about it is grocery buying benefits. So Maryland is using an existing EBT program to make sure that families get dollars on their EBT cards so that they can also purchase meals on their own or food. Certainly.
Do I have any other questions for our secretary? Thank you very much.
Thank you.
So we have some other people signed up. I don't know if they're just with you for information, but
I do not know.
Aisha Holmes and then Kelly Locklear from the Maryland Retailers. You can begin.
Good afternoon, Secretary Lopez, Chair Biddle, and members of the committee. Thank you for the opportunity to offer testimony on Senate Bill 213, the Summer SNAP Children's Act. My name is Aisha Holmes. I'm the director of No Kid Hungry Maryland. Summer is the hungriest time of the year for thousands of Maryland's children. Each year when school ends, families face the reality of ways to snip their budget to ensure that they have enough food to feed their children. They go without other necessities to ensure that everyone can survive. We know that for many Maryland children, school meals provide most of the food that they have for the day. The Summer SNAP for Children's Act has the potential to permanently change that unforgiving reality for 500,000 Maryland children by leveraging over $60 million of federal benefits for the kids. Expanding the Summer SNAP funding to $5 million would enable the state of Maryland to take advantage of the USDA SEBT program, ultimately allowing DHS to reach those 500,000 children with $40 a month for food benefits this summer. What started in 2019 as a modest investment of $200,000 for our kids, Summer SNAP now has the potential to impact 500,000 children facing hunger and poverty this summer. By updating the Summer SNAP legislation, you have the opportunity to transform how children and families address their basic needs. With the new Summer SNAP, we can reach the children who are struggling with hunger over the summer instead of the lucky few. Right now, because of the required match, many jurisdictions cannot participate. With the USDA Summer EBT, they would not have a match, and the children would access these benefits statewide based on the need. Need is determined 3 ways by the USDA. A child has to be eligible for free and reduced meals through the school, or a child has to be on Medicaid or receiving SNAP. I ask for your favorable consideration.
Thank you. Kaylee?
Good afternoon, Madam Chair, Madam Vice Chair, honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Retailers Alliance in strong support of this legislation. I have shared with the committee before that the grocery industry does operate on a 1 to 3% profit margin. So any increases in SNAP do directly positively benefit those stores that are in your communities as well as these recipients. I have talked to the department about this. It's been flagged for me in some jurisdictions that we're seeing decreases for some reason in some SNAP spending. So we're looking into that right now. So any dollars that can be increased and spent in stores is really important right now. We realize you have tough budgetary decisions to make this year, but I don't think that the importance of food retailers and communities can be understated. So with those comments, we urge a favorable report, and I'm glad to answer any questions.
Have any questions for this panel? Thank you very much. And that ends the hearing on Senate Bill 213, and now we'll go to Senate Bill 226. Oh, I'm sorry. We do have a virtual? I don't have that list. I don't have the list. Thank you. Virtually, we have, they're not there? Okay. All right. So back to, that ends the hearing on 213, and we now go to Senate Bill 226.
Good afternoon, Chair Beidle, Vice Chair Klossmeyer, and members of the Finance Committee. It's an honor to be here today with you. And thank you, Chair Beidle, for putting forward this bill. For the record, I'm Carol Beatty. I am the Secretary for the Maryland Department of Disabilities, and I am here to discuss Senate Bill 226, which is titled Human Services Attendant Care Program, Ongoing Additional Supports. And here with me today, it's a great honor to introduce our Secretary of Aging, Secretary Roque, Jennifer Eastman, who is our Director of Community Living Policy at the department, Deputy Secretary Lisa Belcastro, and Assistant Secretary Kim McKay. She is in charge of our programs and communications. We have written testimony, and so the bill is about modernizing and creating more opportunities for people with disabilities within the existing attendant care program, which was established in 1982 and is administered by our department. The goal of the ACP program is to assist individuals with physical disabilities to maintain employment, attend post-secondary education, and prevent placement in a nursing facility. It works on a direct reimbursement model for out-of-pocket expenses and currently only for attendant services. Attendant care is defined as an individual who is hired to assist with activities of daily living, such as personal hygiene, housework, food preparation, and mobility within the home and in the community. Fast forward to 2024, and obviously our world and the needs of people with disabilities and the modes and ways of meeting those needs have changed dramatically. This bill would add flexibility to the program by including what we're referring to as ongoing additional supports as reimbursable expenses in addition to attendant care. Ongoing additional supports could be things like grocery delivery services, laundry services, prescription delivery, rideshare services, or assistance with service animal expenses. These are some of the examples of technology and advancements not necessarily thought about in 1982. At the department, we believe that adding these flexibilities also makes our ACP program more equitable and accessible to a wider group of Marylanders with disabilities. Personal care services are cost prohibitive to many. Because this program is a reimbursement model, individuals must cover the costs, which could put the upfront costs anyway, which could put the program out of reach for many. By allowing a menu of supports options at various price points, we believe we will be allowing more individuals access to the program. Thank you again for the opportunity to present SB 226, and I respectfully ask for a favorable report, and we're happy to answer any questions.
Carol, thank you. Is everyone else here just to answer questions or?
Yes.
I'm gonna
Oh,
test,
I'm
yeah.
sorry. Yes.
Secretary, please.
Woo. I'm gonna,
I'll move over.
oh, wait. Okay, I don't have to get that close to my friend. Thank you, Chair Vital and Vice Chair Klausmeyer and esteemed members of the Finance Committee. I am Carmel Roque. I am the Secretary of Aging. I'm here to testify in favor of Senate Bill SB 226. The Maryland Department of Aging, as many of you already know, serves as Maryland's state unit of aging, administering federal and state funds for core programs that are overseen by the 19 area agencies on aging. These services provide critical support for older Marylanders living in the community. Pursuant to a recent executive order, in January, Maryland Department on Aging launched the Longevity Ready Maryland initiative, which will build upon existing efforts across state agencies, private and philanthropic sectors, and other stakeholders to tackle real-life problems and challenges throughout the full lifespan, taking a whole-of-life course and a whole-of-government approach. Key goals of Longevity Ready Maryland are for all Marylanders to afford and enjoy their longer lives. And you might know that this program serves people up to the age of 64. We wish for them to have increased access to healthcare and retirement supports and promote opportunities for all, regardless of age or ability, optimizing health, wellness, and mobility, and delaying dependency and the costs associated with dependency. SB 226, which would modernize and add needed flexibilities to the Department of Disabilities Attendant Care Program, squarely furthers these goals. The program serves adults up to age 64, assisting participants with severe chronic or permanent physical disabilities.
Finish, Madam Secretary.
Okay, to direct their own care. So much has changed since 1982, and we know that we now use our phones to operate smart homes. We can also have almost anything we need delivered to our home, and we know that AI and robotics will change lives in ways we cannot yet imagine. These improvements that are in the legislation will support more Marylanders in living, working, and attending school with higher degrees of independence in their communities. Programs and related efforts like this provide intentional, concrete ways for Maryland to win the decade and leave no one behind, making it possible for all Marylanders to live with lives of dignity, purpose, and contribution. I strongly urge a favorable report for Bill 226. Thank you.
Thank you, Madam Secretary. Do I have any question? I do. I have a question from Senator Ellis.
Thank you, Madam Chair, and thank you for your testimony. So quick question, Secretary Rose. What happens after age of 64? So this program supports up to 64,
So many of the programs that are provided through the Department on Aging funding, state and federal funding to the local jurisdictions, some of them start as early as 60, but at age 65, people become eligible for their Social Security and Medicare benefits. And that's one of the big changes that occur. The other thing that I think is very hopeful is that we know that people don't miraculously at age 64, 65 become disabled or in need of support. And so the fact that there are provisions for their care prior to them being eligible for services and programs for older people really makes a huge difference.
Thank you. Thank you, Madam Chair.
Thank you, Senator. And Senator Kramer?
Thank you, Madam Chair. I just wanted to share with the committee that I have the honor of being on the State Commission on Aging and working with Secretary Roque, and what an outstanding job she has been doing in her capacity as secretary. So I just wanted to say thank you to her for the great work that she's doing on behalf of such a significant portion of our residents here in the state. Thank you.
Thank you, Senator Kramer. And you know I had big footsteps to follow in.
Thank you, Senator Kramer. I don't see any other questions. I do have one virtual person online, Matt Rice. Here we go. You need to unmute Matt, please.
Thank you for the opportunity to testify today. Honorable Chairperson, members of the committee, my name is Matt Rice. I am the Executive Director of People on the Go of Maryland, which is Maryland's statewide self-advocacy organization run for and by those with intellectual and/or developmental disabilities. We're here in strong support of SB 226 because, as my colleagues have outlined, this is a way to increase the independence of Marylanders, bring a great program into the modern world. And we also hope that if these provisions are successful, they will serve as a model for other programs within the state to take a look at. And we believe as an organization that all people, regardless of disability, have the right to live, work, love, and play in the communities of their choosing. And SB 226 allows more people to do just that. So with that, I respectfully ask for a favorable report.
Matt, thank you for that testimony. Do I have any questions for this witness? No. Thank you very much. It was very helpful.
Thank you.
That ends the hearing for Senate Bill 226. And next we'll go to Senate Bill 211, Public Health Giving Infants a Future Without Transmission Act. Hi, Doctor, is Pam Casemeyer with you? Is she part of your panel?
She's not part of my panel.
Okay, thank you.
Sure. Good afternoon, Honorable Chair Vital and members of the Finance Committee. My name is Peter DiMartino, and I currently serve as the Director of the Infectious Disease Prevention and Health Services Bureau at the Maryland Department of Health. Thank you for the opportunity to speak to SB 211, which addresses the devastating impacts of perinatal HIV transmissions and congenital syphilis in Maryland. The rise in congenital syphilis cases is deeply concerning. Nationally, there has been a staggering 937% increase in reported congenital syphilis cases over the past decade, with Maryland seeing nearly a 300% increase. Specifically in 2022, Maryland reported 46 confirmed cases of congenital syphilis, a 55% rise since 2018. This trend underscores the urgency of the situation. Likewise, in Maryland, the incidence of perinatal HIV has seen a concerning rise. Over the past decade, 18 infants have been diagnosed with perinatal HIV, with a third of these cases emerging in just the last 2 years. Perinatal HIV and congenital syphilis are preventable consequences of no prenatal care, inadequate prenatal testing, and late treatment. Perinatal HIV can cause lifelong immune deficiency and life-threatening infections. Congenital syphilis can cause infant death or severe complications, including blindness, deafness, and developmental disabilities. SB 211 amends prenatal HIV and syphilis testing requirements and HIV reporting requirements. Requiring universal syphilis and HIV testing at the time of delivery ensures equal access to testing for all women at delivery and equal access to immediate evaluation and treatment for all infants. SB 211 will have a short-term fiscal impact that will likely be offset by long-term cost savings for the lifetime costs of caring with children diagnosed with either syphilis or HIV. The cost of syphilis testing is approximately $30, while the cost of treating an infant with congenital syphilis is more than $1.1 million for just the first 2 years of life. The average cost per HIV test is $24, while the lifetime cost of care for an infant with HIV could be well over $1 million, according to national analysis. In recognition of the profound potential the bill has to protect infants in Maryland, the department strongly supports SB 211 and urges a favorable report on the bill. Happy to take questions.
Do I have any questions for Dr. DiMartino? Senator Lamb.
Thank you, Madam Chair. So thank you for bringing forward this bill. Certainly greatly appreciate all the work that's being done by the new administration when it comes to HIV and prevention. I noted in the bill folder that there is unfavorable testimony on this bill from the Center for HIV Law and Policy. It looks like they're concerned in part because Maryland counties have a special crime related to the in statute have a special crime related to the transfer of HIV. And I agree that continuing to treat HIV uniquely in the criminal code undermines kind of the goals of public health that we're trying to aim at. Does the department support looking at HIV criminalization, at the HIV criminalization statute as part of a broader goal of ending HIV transmission?
So I believe the specific concern here is the changes to HIV reporting, and none of our health data has ever been used in any of the criminal cases. And there's been about 104 in the past 20 years in Maryland. So the two are not directly related with the reporting associated with this proposal.
Okay. Doesn't fully answer the question, but thank you.
Sure.
I was wondering the same thing, Senator Lamb, so thanks for asking the question. Do I have any other questions for Dr. DiMartino? Thank you very much for your testimony. Next, we have Pam Casemeyer.
Hello, Madam Chair, members of the committee. I'm Pam Case Meyer, and I'm actually here on behalf of 3 of our clients. Not only the State Medical Society, but as or more importantly, the American College of Obstetricians and Gynecologists and the Academy of Pediatrics in support of this legislation. We have seen an increase in incidence of HIV within newborns and in pregnant women, and believe that the additional requirements that are included in this bill will begin to help us create a better understanding, as well as provide additional resources and tracking to keep that from continuing to grow. The other issue, which you will very rarely hear, as you know, where it changes the word physician to healthcare provider. You have certified nurse midwives, you have certified midwives, you have others that are also providing obstetrical care. And all of us now will be involved in testing and ensuring that we are not missing something within women that also could severely negatively impact their newborns. So we look forward to working with the department as we go forward with this, but are very much in support of the legislation.
Ms. Case-Meyer, did you hear Dr. Lamb's question, Senator Lamb's question about the criminalization?
No, sorry, I didn't. I was just ran over from another hearing. I'm
So
sorry.
apparently this is in testimony from the Center for HIV. The bill would expose PLHIV who are pregnant to increased criminalization. Moreover, the proposed bill would discourage Black and brown parents from engaging in healthcare by exacerbating medical distrust and would undermine parents' rights to choose how and what to feed their newborn. So I think the criminalization piece is an important part. If you could maybe take that back to your clients, I'd appreciate that.
Sure.
And we'll
And
talk
I'm not sure how it is criminalized. Maybe that's what I don't
There's
even
other parts of the
understand.
Maryland Code about infecting people.
But I think that was I think that's purposeful infection. I think that's knowingly infected. What we're seeing is a lot of incidents where people may not even have any understanding they were exposed. They weren't knowingly infected. It may be the partner they had didn't know either that they were HIV positive. So there's nothing in here that we believe would, and I'll go back, take it back and talk about it without question. But I think what we're seeing under most of these circumstances is it's being identified in people that are totally surprised by it or aren't anticipating it, and not necessarily even that they were purposefully infected. So that, but I will ask about that, but that hadn't come up in the conversation with the obstetricians and pediatricians.
We may just need to clarify. Senator Lamb?
Yeah, thank you. Let me try to help here. So the statute criminalizes knowingly transmitting HIV to somebody else. In that way, it disincentivizes someone from looking up or checking on their status, getting tested for HIV, because that could result in someone, once they know their HIV status, of knowingly transmitting it to someone else. So it really disincentivizes someone from checking and getting tested for HIV, because it could lead them to know that they have HIV, which could hit this part of the criminal statute.
So this.
So as someone.
But I guess this bill being related to testing pregnant women at various stages of their pregnancy and later, if you're pregnant and then learn that you have HIV, you weren't knowingly infecting your unborn infant because you didn't know about your HIV before you were pregnant. So that's not a knowing. If you learn about it after the fact, you weren't knowingly doing it. If I would say, and again, we'll go back and look at this, but I would say if I were a pregnant woman and said, well, I just found out I have HIV, let me get pregnant, and then I'll transmit it. That's a very, very different circumstance than a woman who is already pregnant being tested and learning that she's positive and or the infant is positive, those are not knowingly infecting. From
I
a
don't
legal
think that was the
standpoint.
point that I was trying to
Okay.
make. I think if someone, I think it disincentivizes someone from wanting to get tested because that will allow them to, that would lead them to know their HIV status at that point. That's the point that we're making.
But I guess wouldn't someone, if you were having a baby, want to know? Because you couldn't be criminally, nothing could be criminal about that, but
But
you
the
would.
moment that you know, then you could be charged criminally if you accidentally transferred it to someone else. If
We'll
you were,
work
to-
on it.
if you were to engage in activity that ended up transmitting it later, years later, months later, weeks later, after the birth of the baby,
Okay.
you know at that point that you have HIV and now you're transmitting it to someone else. That becomes a crime.
Okay. And
We'll
isn't
work
there
on it, Senator.
legislation to withdraw that criminalization? Isn't there
We've
a
tried.
bill in the
That
house?
hasn't passed.
I know. Okay.
Okay.
Well, we
We'll
will
work
talk
on it.
about all of that, but from the obstetricians and pediatricians' belief is that's such a narrow potential possibility that the significant public health benefit from doing this with pregnant women and infants is dramatic in terms of its ability to reduce what we are seeing as an increased incident in newborns and in pregnant women.
Thank you very much, Ms.
Thank you.
Casemeyer. That ends the hearing on Senate Bill 211. Our next bill is Senate Bill 244, Public Health Clean Indoor Act. We have Dr. Clifford Mitchell. His panel is Dana Moncrief and Lauren Levy. Thank you.
Thank you, Chair Bidle, Vice Chair Klausmeier, members of the committee. I'm Dr. Clifford Mitchell. I'm the Director of the Environmental Health Bureau at the Maryland Department of Health, and I want to express our appreciation for your hearing us today on Senate Bill 244, which is a revision of the Clean Indoor Air Act. For 16 years since the Clean Indoor Air Act was passed in 2007, Maryland's children, its workers, and all of its citizens have enjoyed the public health benefits of cleaner indoor air since that passage, with all of the health and economic benefits that have come from not being exposed to the hazards and costs of secondhand tobacco smoke. However, in 2007 and 2008, when I had the privilege of working on the regulations for that Clean Indoor Air Act, no one was talking about electronic smoking devices because they had not yet been popular. However, since that time, we've seen a dramatic increase, particularly amongst youth, but also amongst the adult population in the use of electronic smoking devices with all of the attendant risks and harms that exposure to vaping aerosol have in the indoor environment. And secondhand vape, the emissions from these electronic smoking devices, contains a large number of harmful chemicals that have been shown to cause both irritation and health effects in the population and to negatively affect people who are exposed to them secondarily in indoor areas. Adding electronic smoking devices and updating the Clean Indoor Air Act, which is what Senate Bill 244 does, will protect members of the public and employees from secondhand vape exposure from both tobacco and from cannabis-related aerosols, and further reinforce the norms that have led to dramatic improvements in health with the passage of the Clean Indoor Air Act. It also significantly is very, very beneficial for the business community and business owners to have Senate Bill 244 enacted, as it will lead to simplification of questions that come from many business owners alike about whether or not vaping is allowed in indoor areas open to the public. By adding electronic smoking devices to the Clean Indoor Air Act, we can strengthen the intent of the Clean Indoor Air Act, and which is to preserve and improve the health, comfort, and environment of the people of the state by limiting exposure to environmental smoke, including vape. The department looks to the members of this committee to continue Maryland's commitment to protecting the health of Maryland residents and urges a favorable report on the legislation, and we thank you.
Hold questions until the end of the panel. Thank you.
Hi, I'm here just to answer questions, but for the record, my name is Dana Moncrief, and I'm the Director for the Center for Tobacco Prevention and Control at the Maryland Department of Health. Thank you.
Good afternoon. My name is Lauren Levy, and I serve as the Health Officer for Cecil County. I'm here on behalf of the Maryland Association of County Health Officers to express our strong support for Senate Bill 244. Dr. Mitchell has outlined some of the many reasons why the updates to the Clean Indoor Air Act are necessary. At the local level, we're especially concerned about high rates of vaping among youth. Our most recent data indicates that 1 in 4 high school students in Cecil County reports currently using a vaping device, and 20% or 1 in 5 middle school students report ever having used a vaping device. To see this level of vaping among youth after the great successes in reducing tobacco cigarette use over the past 20 years is deeply concerning. In addition to protecting air quality, one of the Clean Indoor Air Act's major achievements is helping to normalize non-smoking and smoke-free environments. This bill is about recognizing that there's been a targeted shift in how our children view and accept the use of tobacco. We know that nicotine exposure during adolescence can negatively impact learning, memory, and attention, in addition to the physical harms associated with inhaling vapor smoke directly from electronic smoking devices or through secondhand exposure. Vapor smoke contains numerous chemicals that have been proven toxic, including lead, which has been shown to impact fetal development, and benzene, which has been linked to leukemia in children. This bill will help to protect indoor spaces like libraries and grocery stores. It provides important support for businesses and other organizations as they seek to protect the health of their staff and customers by limiting exposure to secondhand vape emission. MACHO strongly supports Senate Bill 244. It will limit secondhand exposure to emissions from vaping products, reduce indoor air contamination, and most importantly, protect the health of people across the state. Thank you for the opportunity to speak this afternoon. Thank you for your consideration and support of this bill.
Thank you. I do have a question about enforcement. I think we seem to strongly enforce cigarette smoking. Will be additional enforcement now with vaping?
Actually, I think, oh, sorry, go ahead.
No, go ahead.
I think from the local standpoint, it actually makes our jobs easier because it provides consistency across the different types of tobacco use products, instead of having this disparity between electronic smoking devices and cigarette smoke.
So one of the big issues we hear about are in bathrooms in schools, middle schools and high schools. And I know there's devices that schools could use to alert them when there's vaping going on in a bathroom. Do you know about those devices?
I do. They have actually been utilized in Cecil County.
So I wonder from the state point of, Dr. Mitchell, if we could do more to encourage schools to put those devices in bathrooms and enforce at schools. I mean, I have children that tell me they don't use a bathroom all day in high school because they can't stand the vaping in the bathrooms. I think it's become a really serious issue in our middle schools and high schools.
I think Ms. Moncrief may be able to speak to that.
Thank you. So these are some devices that we're really still learning about. I know there have been issues reported within schools that it constantly goes off. The alarm goes off constantly. So that also causes an issue. So these are things that we're still looking into. So before I think we would make a recommendation, we want to learn more about the devices themselves.
I would like to ask you to make that a priority, please.
Okay.
Thank you. Senator Lamb.
Thank you, Madam Chair. So obviously the Clean Indoor Air Act has been a great success, I think, here in Maryland, and trying to retain it and elevate it and support it is obviously really important. The current Clean Indoor Air Act is supposed to limit the sale of non-tobacco related products to tobacco shops to just incidental sales, as you're aware. But I think this committee and myself has seen several examples across the state of events where alcohol and cigars are being jointly sold and also consumed. What can we do to help ensure that the spirit of the act continues to be protected?
Senator, thank you for the question. We have been working very, very closely and continue to work very closely with local health departments, with businesses, to clarify and make sure that we are consistent in our application of the definition of a tobacco retailer as it was originally written in the act and as we wrote it in the regulations. Just to recall and remind the committee, I know you are aware of this better than I, but the definition of a tobacco retailer is a business which the primary purpose of which is the retail sale of tobacco or tobacco-related products, and the sale of other items is incidental. And we have historically, since 2008, worked very closely with the business community to ensure that that interpretation is consistently applied across the state. We know there have been reports of other businesses that are not primarily tobacco retailers trying to invoke that law. We continue, or that exemption, we continue to provide guidance and provide enforcement where appropriate to be clear that the exemption is narrowly tailored to apply to businesses, the primary purpose of which is the retail sale of tobacco and tobacco-related products.
And then just a quick follow-up, is there a definition of incidental, and do you support the effort to make a definition of incidental?
Senator, we have consistently, because it was discussed in the original passage for years, there has not been a definition of incidental. We have applied a practical definition with many jurisdictions. The Baltimore City, I believe, is 25% has been adopted as an ordinance by Baltimore City, which has that authority. And we have provided guidance that certainly businesses who derive a majority of their overall gross revenues from the sale of food or alcohol would not, in our opinion, qualify.
Okay, thank you.
Senator Reedy?
Just a technical question, if I might. Cliff, maybe is for you, although anybody could probably answer it. In the bill, so we're updating to say vaping and smoking are considered the same, which makes sense. Why is there language that there's already language that requires you to have a sign prominently posted? And now we're saying it should say not just, smoking or vaping, but why are we now saying it? There's additional language that's saying you shall be conspicuously posted and property maintained. I mean, is that necessary to be that specific in state law?
Senator, thank you for the question, and it's nice to see you. And I think
we've been chattering. Some of our folks in my county and we've been talking a little bit lately, I think. So yeah.
Yes, indeed. The answer for that is we actually wrote that language into the regulation. So this is updating the law to be consistent with the regulation as well.
It already exists.
Which yes, we've always held that the sign had to be conspicuous for exactly that reason, because we were concerned. We wanted to make sure it was very clear to people.
In this case, I actually like it because I like that if we're going to have it in regs, make it clear in law. That actually makes sense.
Senator, if you are happy, I am happy.
Thank you, Madam Chair. I have a couple of questions for you on this bill. The chair mentioned something about school and our schools and students vaping in schools. As I'm looking at this bill, it doesn't mention schools at all, but is this to cover schools? Is the intention to cover schools? I know we want to add vaping to the law itself, but is the intention to cover schools as well?
Senator, schools have always been covered both in the Clean Indoor Air Act, and MSDE may or may not have policies of its own to cover those. But those schools would be considered indoor areas open to the public under the definition that was adopted in the Clean Indoor Air Act.
And so currently does schools already have these signs of no smoking, no vaping? Because under the bill, you add that there needs to be additional signage.
I believe that every school I've been in has that signs conspicuously posted.
That includes no vaping as well?
No, does not include no vaping.
Got it. And
not that I'm aware of.
And I'm only asking about.
Could differ between schools, I'm sure, but not that I'm aware of. Yeah.
And I'm asking about the schools because I recently read an article in that a student who was, I think, the valedictorian was caught vaping in school in Texas, and they literally almost expelled this person. And so I wonder, what is the for in our schools currently, what is the penalty for vaping right now? Do you know that answer?
this over. So within our schools, and Lauren, you can, answer this as well too. We really encourage alternatives to suspension. So there at the local level, certainly, and in schools, anyone caught vaping, any of the youth caught vaping, they go through education or other sorts of programs to help them to stop vaping or explain why it's important or what the dangers are. So there, certainly we encourage that alternative to suspension versus being suspended or fined within the schools.
I'm sorry, who do you represent again?
I'm sorry, I'm Dana Moncrief. I'm the director for the Center for Tobacco Prevention
Got it,
and
okay.
Control at the MD.
You're not with the school system? Fair
No,
enough.
I'm
Okay,
not.
cool. All right. Just my last question, because Senator Lamb brought this up. In our county, we're considering, well, someone proposed, I'm not considering, but someone proposed legislation to expand the use of alcohol or sale of alcohol in tobacco shops. And one of the issues that comes up is that we currently allow tobacco to these cigar bars or cigar lounges to have BYOB. So they bring their own beer, bring their own liquor, alcohol. They could literally bring a bottle themselves if they wanted to in there. And that part isn't regulated. How much they drink isn't regulated, but we allow them to smoke indoor and bring their own. And we already know currently that there are some cigar bars that actually do sell alcohol. So there's an inequity there. So can you just give me some, like, how do we resolve both issues? Whether or not someone can literally bring a bottle of alcohol in there and drink the entire thing if they wanted to. But then but it's against the law to sell alcohol in these shops. How do we fix this issue?
Senator, I thank you for the question, and I know this is a question that has come up before. We have consistently applied what I think is a fairly clear definition to people who have asked this question, which is the intent of the legislature, as we understand it, based on the passage of the Clean Indoor Air Act, was to allow smoking in indoor areas for tobacco retailers. That is, people whose primary business is the sale of tobacco and tobacco-related products, and in which the sale of other products is incidental. Almost all of the establishments where this question has come up have been bars and restaurants where the intent of the legislature, as we understood it, was clear that those were considered areas where the primary business was being a bar or a restaurant, not a tobacco retailer. And therefore, we have consistently said that in those settings, we believe that the Clean Indoor Air Act would not allow for an exemption and that they would be subject to the restrictions of the Clean Indoor Air Act.
Is that a fine?
So the way that works is that if there's a complaint about those, then a local health department would investigate. They would then write a letter advising that there had been a violation. The first violation has no financial penalty associated with it. And then there's a stepped increase of fines for repeated violations.
And that's currently in statute.
That is currently both in regulation and in statute.
All right, last question, Madam Chair. So they're able to bring their own alcohol to these cigar bars. Make it make sense to me. How is that even?
So, Senator,
and if we're not going to allow them to sell it, but we are allowing them to bring it in for themselves.
So, Senator, I will say that how a jurisdiction regulates the allowing alcohol to come in, which is not sold, is not something that is contemplated or covered in the Clean Indoor Air Act. So the statute is silent on that question, and I can't really comment beyond that.
That answers my question. Thank you.
And Senator, that's really a county liquor law issue, as you'll learn when we start doing the alcohol bills. I think the counties may be allowed. I know in my county, that's what happened. The county liquor board passed some changes.
I appreciate that, Madam Chair, but I know that it's also a statewide issue, and we regulate alcohol throughout the state.
Well, we can.
Right.
We can.
Correct.
But at this point, some things have been done county by county. So we'll talk more about it.
Cool. Thank you.
Senator Mouts.
Thank you, Madam Chair. And it's interesting with the discussion we just had to flip it around and go back to schools. And I was thinking about this. So with this new policy in place and with those enforcement actions, so we were talking about going to the establishment saying, you're not exempt. Well, if you go to a school, is it the school that is the target of the health department action, or is it the student? So if we do this and the parents are upset and they call the health department and say, you know, Johnny's in school and there's vaping going on and the school isn't doing enough about it, is the health department going to go to the school, to the principal and say, you're in violation? Here's the citation, and how does that work?
So Senator, I would say that as both a state or a government agency, things don't work exactly that way with, and I can't comment on the State Department of Education's own policies in this regard, but I will say that, and Lauren Levy may have more to say on this from a local level, but we would certainly, the Clean Indoor Air Act enforcement is primarily related to private sector commercial activities. There's a whole different set of regulatory requirements, also part of the Clean Indoor Air Act, where, for example, MOSH would look at this as a workplace and could potentially act as for a workplace establishment. But schools are a separate category that are contemplated very differently. And Lauren, I don't know if you have experience with this at the local level.
Yeah, I mean, that we would not be treating the school system as we would a private business in terms of enforcement and enforcement checks even. You know, in terms of student use in bathrooms, that's obviously something we're very concerned about. We're hearing the same reports with regard to students not wanting to go to the bathroom. Our focus is on protecting public health. And so working with those students to prevent initiation of use in the first place, but for those who have started using vape, getting them into cessation programs and providing those resources.
Yeah, and so, I mean, full disclosure, my interaction on this with the Department of Health has always been from the retailer, those types of interactions. But but in the scenario though, with the parents filing the complaint or saying, I mean, because this bill would apply to schools also, or schools covered by another, is this already banned in schools?
So it is already, my understanding, and
I believe it's correct.
I believe, but that, I believe that, and I can't speak to this, so we can get back to you on this, but this would be a question for the Department of Education, because I think they have policies on their own.
What about other government buildings? Are they covered by this?
So other government buildings, and this is the Clean Indoor Air Act has a section that deals with the private sector, which is what the Department of Health deals with. It has another component, which is under the Department of Labor's Maryland Occupational Safety and Health Agency. And so if it's a government agency, and in that regard, that is considered generally an employer-related issue where MOSH would go in and do an investigation. And then, however, MOSH deals with government agencies, which is a whole separate process, would be the way that would be treated.
So the direction to the parent would be to call MOSH.
Well, or most important, so again, I don't want to speak to a matter of law, but generally speaking, when parents have complained about this, the first step is to talk to the local Board of Education, which has authority over the schools.
Right. Oh, thank you for clarifying that for me.
Thank you, Senator.
I don't see any other questions for this panel. Thank you very much for your presentation.
Thank you, Senator.
I do have two additional people to testify, Christopher Davin and Kathleen Hoke. Thank you both. You can begin when you're ready.
Thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm Christopher Daffin, a student attorney on the Public Health Law Clinic at the University of Maryland School of Law, and I'm testifying in support of SB 244. The Clean Indoor Air Act was signed into law in 2007 to protect the health, the comfort, and the environment of Maryland residents by limiting their exposure to environmental tobacco smoke. Since then, vaping has become more popular. This bill aims to extend the protections of the Clean Indoor Air Act to include vaping, including that of tobacco and cannabis products. The bill specifically targets places where smoking is already currently prohibited. Now, vaping not only undermines our progress in reducing smoking rates, but it also poses a significant risk to those who have quit smoking by triggering relapse. So many Marylanders have climbed a mountain to free themselves from smoking addiction. And after the Clean Indoor Air Act, people were able to quit smoking and stay that way. Since then, Maryland's smoke-free environments have been instrumental and providing solace and support to former smokers. Allowing vaping in these spaces threatens to unravel all of their hard-fought progress. Vape usage is on the rise. While Maryland's vaping rate increase is below the national average, to maintain our spot as a national leader in public health, this body must give this issue enough attention and legislative action. This legislation is not just a matter of public policy, but an expression of compassion and empathy for those on their journey to a healthier and addiction-free life. So to safeguard the health and well-being of all Marylanders, I urge a favorable report on SB 244. Thank you.
Madam Chair, Madam Vice Chair, members of the committee, I'm Kathy Hoke, a professor, right now a really proud professor at the University of Maryland Carey School of Law, where I also direct the Legal Resource Center for Public Health Policy, providing technical assistance to you all, to state and local government officials, legislators, advocacy organizations, specifically on tobacco-related issues and some other issues. When I saw this bill come in, I thought, oh, I'm testifying on behalf of the Legal Resource Center, but I also feel like I'm bringing with me the deep and broad coalition of folks who worked for 10 years as Smoke Free Maryland to get the Clean Indoor Air Bill passed in 2007. And I'm still grateful for that experience. But I'm also reminded that back then, the Legal Resource Center got lots of calls from employers and businesses, sometimes even restaurants, saying, hey, are we allowed to prohibit smoking even though it's not part of the law? And we said, sure, you can. And they lamented that the law wasn't there for them because it was difficult for them to enforce the policy when it wasn't the law. Flash forward 10 years, obviously we've had great accomplishments with the Clean Indoor Air Act, and now we get those calls about vaping, the same calls. From the same people asking the same questions. And we say, of course you can prohibit vaping in your establishments. And again, they lament, hey, I don't want to do it on my own. I wish there was a law. I live in Baltimore County. I was recently in a small business owned by a friend of mine, so she'll remain confidential. But she has a sign in her establishment that says no smoking or vaping by law. And I said, you know, Sharon, oops. So you know that's wrong. And she said, I know, but it's so much easier than me trying to explain it to people why I don't want them to vape in my shop. So I think there's lots of support for this. It actually sounds like in this committee, there's lots of support for this very narrow bill. And for that reason, I urge you to pass it as it is. I think there are other things clearly that we have to work on in Clean Indoor Air, but let's let this small enhancement to our existing law pass as is. Thank you.
Thank you, Professor. Do I have any questions for this panel? Oh, Senator Washington.
Thank you. Does the Clean Indoor Air Act cover condo buildings, their areas within those the shared areas within those condo units?
It only covers the shared areas, but yes, it does. So it doesn't cover individual units.
Correct.
Of course, condominium associations have the ability, and some have across the state with our assistance, devised and adopted smoke-free policies, including inside units.
I have a bill that you would like. Thank you.
I know. Senator Kramer has one. All of you have bills I like. If I can just, on the Department of Education, there is actually, and pre-existing the Clean Indoor Air Act, Maryland State Department of Education had smoke-free schools, and now they have by their own policy vape-free schools. And that is, I think Dr. Mitchell was hoping this was the law, and he's right, that is actually all enforced by the Department of Education. So it's kind of outside the scope of the Clean Indoor Air Act to the extent that they had pre-existing laws. Whether they're doing it or not, different question. But from a legal perspective, they have had smoke-free and purportedly vape-free schools for some time. Yeah, I'll call you. I will.
Thank you. That ends the hearing for Senate Bill 244. And now we will go to Senate Bill 76, Senator Lamb. And it looks like your panel is Barbara Ricardo, Daniel Shattuck, and Bruce Hardick.
Hey. Good afternoon, members of the Senate Finance Committee. For the record, Senator Clarence Lamb, District 12, presenting SB 76. For the context, continuing care Retirement communities, or CCRCs, are professionally managed retirement communities that offer services from independent living to assisted living. The goal of this bill is to increase transparency and accountability for CCRCs. It increases the number of retirement community residents on the governing boards of each community and mandates that a provider must meet at least quarterly to discuss financial statements with a designated representative of a residents association. Additionally, the Department of Aging will be required to collect and report on grievances from providers. These transparency measures will help improve the relationship between residents and providers by ensuring that residents have a greater understanding of the governing work in their community. The bill also ensures that residents of their families receive their refundable entrance fees back from providers in a timely fashion by implementing a method where residents will get their fee back in the order that they were vacated their unit in, rather than when their specific unit becomes reoccupied. Residents or their families have reported long waits for these fees to be refunded under the current system. By issuing these refunds in a sequential order, residents who have moved or families that are grieving the loss of a loved one will potentially receive their entry fee faster and have a better idea of when they will be getting their money back. This will only apply to new contracts, so CCRC owners will be able to phase this new system in. It's also worth considering that families trying to recover these fees are often up against a large entity or company with far more resources at its disposal than individual residents. Changing this to a sequential process of refunding entrance fees will help equalize this process. And that is the bill. Happy to pass along to other members of the panel and take any questions at the end.
Madam Chair, members of the committee, I'm Dan Shattuck here today on behalf of the Maryland Continuing Care Residents Association. Obviously here in support of the bill, I want to take just a few seconds to again go over what a continuing care retirement community is for those who aren't too familiar. It's a really complex model of senior living. It provides independent living, assisted living, and often skilled nursing all on a single campus. In addition, the CCRCs provide services including meals, housekeeping, recreational facilities, in addition to the assisted living and skilled nursing. Now, there's really two main ways that CCRCs are funded. The first is through an entrance fee, which the incoming resident would pay. It's often in the hundreds of thousands of dollars. The cost will vary based on the size of the unit that they're moving into and whether or not there's a provision for a partial refund or entire refund of their entrance fee when they die or when the contract terminates. These entrance fees are often used for capital expenditures, although sometimes they can be used for operating expenses. And then second is the monthly fee that the residents pay that helps support the ongoing operations of the facility. Now, in this bill, we do put forward a change to current law with respect to refund of entrance fees. Right now, the entrance fee is refunded or where there's contracts that allow for the refund of an entrance fee. It's done when the unit is resold or reoccupied. We've heard of instances where there could be a delay in the reoccupying or resale of a unit, maybe because renovation has to occur, it has to be updated, or there might be more desirable units to sell. New Jersey took a look at this and they passed a law that creates a sequential refund policy, which basically means when the individual would vacate their unit, they'd be assigned a number and it would be sequential 1, 2, 3, 4. And then the refund would come out of the sale of all vacated units, not sell one, refund one, sell one, refund one. It would be a big pool. We think this provides some clarity, some transparency, and then also lets the resident know where they are in the order of refunds.
Madam Chairwoman, members of the Maryland State Finance Committee. I'm Bruce Hartung, retired clinical psychologist and Lutheran pastor, but now, as a retiree, I serve as president of the Maryland Continuing Care Resident Association, a group of more than 2,600 residents in 21 different CCRC communities in Maryland. Our CCRC communities number well in excess of 20,000 people. Here's what our bill addresses. CCRCs exist because residents pay an entry fee and a monthly fee. The entry fee is essentially an interest-free, unsecured loan. Residents are the major financial stakeholders. They can deserve a significant say in how the community in which they live is being managed. We support two resident elected members of the governing boards, ensuring better representation and understanding of resident perspectives. Entry fees, our second address, is often in the hundreds of thousands of dollars returned to the resident should she or he leave, or to the estate when the resident dies. Refund occurs when the previously occupied unit is reoccupied. We want to change that and say refunds occur in the order in which the person has left by leaving or by dying. Those who oppose this say it messes up their financial model. Apparently, this is not the case in New Jersey, where it has been adopted, and not in the Erickson communities, where it seems commonly used. In looking at this, please beware of apocalyptic language about this. We're not offering the end of time for CCRCs. And please beware of language that would suggest that just because we are older adults, we would have difficulty understanding the complicated matters. We believe these are small steps. Questions and conversations are welcome. We energetically urge a favorable response.
Madam Chairman, members of committee, this is Barbara Brocato, and I'm here in support of Senate Bill 76. I just want to say to this committee, I've been working with MACRA for 30 years, long history. MACRA has led the way for a very, very good body of law around CCRCs and protection for residents, as well as security for the facilities. The opponents will say Maryland's the most regulated state. Well, I want to ask, well, how does Maryland compete with the other states where you operate in? There are folks behind me that operate in a number of states. In Maryland, things have been healthy and stable. There's some couple of just instances in this body I have to recall, which was when I first started in 1994, Senator Bromwell was chair. I was up at the table with the residents supporting the first outline of protections. Tom Bromwell there. The opponent there was John Erickson. John's now all over the country with facilities. He was the opponent in the Department of Aging in the back. And Tommy said, everybody get together and try and resolve this. You know, another thing I want to remind this committee, I don't know who was here, the vice chair was. Former Chair Dolores Kelly lived this with us. She served on the continuing care advisory committees. And at 1 year to the opposition, she said, we've got to get this right because I'm going to move there when I'm older. I would say we're talking about resident protection here, having an additional resident. The opponents will say they're all about transparency. Well, having some resident voice in policy makes for a sounder and healthier community. I seriously ask for your support, and we'd be glad to answer any questions. Thank you.
Senator Ellis.
Yeah, thank you, Madam Chair. And so it's an interesting concept of the continuing care retirement communities. So it's my first time really hearing about the numbers. Being a CPA, when you talk about the numbers, it's kind of intrigued me. So you're saying that to go into one of these communities, you have to pay an entrance fee, which is typically how much generally?
Well, typically hundreds of thousands of dollars.
And when they exit, whichever means, that fee is refunded to the estate or to the individual. Is that what I heard?
Depending on the contract. So it could be, for instance, in my case, 95% of that fee will be, when I die, refunded to my estate.
Yeah. Okay. So that's a typical.
But it could be 50%. Could be whatever the contract is.
Okay.
Yes.
So why is that done? Why is that requirement for that entrance fee there? And it's so high.
Well, that's a great question.
I know it is.
That perhaps our management folks would want to answer rather than
No,
me.
you have an idea. Take a
But
stab at it.
I have a sense
Yes, you do.
of it that, of course, they need the money. It's also part of the financial model, which is the money comes in as an unsecured, non-interest bearing loan and then is used for the needs of the community. That could be operating expenses, that could be loans, that could be bond payments.
But the money, if the money is used, it won't be there to be returned. So
Correct.
that's not a usage.
Yes, but you need then more people coming in to make entry fees in order to continue the cash flow.
I understand that. So the money is not really used because it's there and it's maintained and it's returned to the estate or the individual upon exit. So.
If I
Yes,
could on
Mrs.
that
Scott.
last question, Senator, say, no, this money is not escrowed. There is no interest on it. Right now, communities, I'm sure, try and work hard to resell units, but their priorities in pecking orders. And there's situations when there are more vacancies than at other times. Our residents have expressed difficulty over time, sometimes having to wait years to get the return of their deposit to their estate or if they leave. That's a hardship. Now, and so these monies may be used for operations. I don't know if there are other ways to protect these dollars so we know that they are there. But I would say that what we've done in this bill, we think is very straightforward. It's queuing people up so the return of the deposit happens in accordance to when the unit is vacated.
Okay, good. Thanks.
I don't think it's complicated.
Okay, well, there's complex and complicated, and those, we won't go into that here. But so there are, in addition to the deposit when someone moves in, there are monthly payments. How much are the monthly payments average, say? Is it equivalent to like a rent, like $1,000, $1,200, $1,500 or?
Or 7,000, 8,000
per
month.
Per month, yeah. Yeah. I'm concerned, I'm going somewhere. I mean, it's a lot of times in our society, there are barriers to entry, and I'll use that term directly. And a lot of it is meant to go around equal opportunity housing laws. And I think about, individuals got to have the resources to go there. Yeah. And when that resource is given back to the person, that money is not used. It's there someplace floating around. And when they have to pay that monthly fee, I think a lot of these historically, how people have gotten around equal housing laws is creating these high prices of entry into a community and stuff like that. And I'm really concerned about that when I'm not understanding exactly, So I would ask, I would look at numbers for the racial makeup of these communities, because a lot of times that's how the folks with the generational wealth, which is the Caucasian Americans, have kept Blacks out of these institutions, drive the price up, come up with a scheme to make things so expensive, so even a middle class, upper middle class person can't get in there. But folks who have inherited wealth way back from slavery, and that money's still flowing around because money does not disappear, okay? It just keeps going to the next generation. People can take that money and live a life that is reflective of what it was way back when, where my ancestors were in slavery. And I'm concerned about that. And this sounds like a scheme like that, but it sounds like, I'm not sure. But I'm really troubled by it. And I'm going to do some more research on it and see some numbers. So thank you, Madam Chair. I just had to get that out.
We can have a discussion. I take care of 3 elderly folks. I can give you a little background, but thank you.
Okay.
Do I have any other questions for this panel? No, thank you very much.
Thank you.
We have one more favorable with an amendment, and that's Isabella Shykoff. Thank you.
Good afternoon. Madam Chair, members of the committee, my name is Izzy Scheikoff. I'm the Director of Housing Services with the Maryland Department of Aging. We are here today to urge you all to report SB 76 out favorable with amendments. As has been previously testified, there are about 20,000 people in Maryland living in 36 different CCRCs scattered around the state. If you all have not, if you're not familiar with these organizations, I would urge you to visit. They're nice. They're nice places. CCRCs serve seniors and offer senior care in various levels, but they're different from assisted living places, 55 plus communities, different from senior apartments in that they have insurance-like qualities. So all residents have to agree to sign a rather sophisticated contract that basically promises that they're going to take care of you till the end. And they offer the kinds of cares and services that would that estimate how long they think you're going to live and how much money it's going to take to care for you for the entirety of your life. Maryland Department of Aging is more involved in the oversight of CCRCs than any other kinds of senior care organizations because the investments that the residents make and the significant amount of money that they put down. So we're focused on the financial viability and health of these organizations. They're rigorously scrutinized on an annual basis. We support the provisions that increase transparency. We have concerns about the language that changes how entrance fees are refunded because we understand that the organization's financials are predicated on a certain sequence in which entrance fees are refunded. And we're happy to work with the sponsor and the players to come up with some solutions on this bill.
Thank you for that testimony. I think we're going to take you up on that offer to help. I don't understand the sequential refunding because if you have a unit that's sold quickly and maybe another unit that needed repairs and it's sold later, it seems like when the unit that's sold quickly should get refunded, not wait till, down the line.
I will leave that to the people who follow me to explain that. I will tell you, though, that I think that a lot of what we're seeing in this bill is really the continued fallout of the pandemic, which was a gut punch to these organizations because people stopped moving in. Mm-hmm. A lot of people perished, staff left, and it's taken some years for them to get back up on their feet and begin the increasing their occupancy levels. And that's how this whole model works. We have to have a continuous flow of people coming in, paying for their units so that the people who are leaving can be refunded what's remaining of their entrance fees.
Thank you for that. Do I have any other questions for Izzy? Thank you for testifying. So I have a panel of unfavorables: Allison Sabrowski, Wendy Crampton, Todd Andrews, and Dana Kaufman. Allison, you can begin when you're ready. Thank you.
Thank you. Thank you, Madam Chair, Madam Vice Chair, and members of the committee. My name is Allison Sabrowski, here today on behalf of Leading Age Maryland. You have a written testimony, and we are here in opposition to Senate Bill 76. We represent 150 different not-for-profit aging services organizations, including the vast majority of CCRCs in the state. And following last week's hearing in the House on the cross-file of this bill, House Bill 68, there will be a work session to discuss the legislation. We appreciate the concerns of the proponents and are willing and eager to find ways to move forward together. So I wanted to let you all know that. In terms of the bill's current form, from both an effective governance and financial sustainability perspective, we do have great concerns. The two items that are of greatest concern are related to the sequence for the return of deposits and increased resident representation on CCRC boards. I'm joined by two CCRC leaders in Maryland who will share some additional insight around the CCRC business model and current state regulations and requirements. Briefly, I want to address the issue of resident representation on governance boards. This bill would seek to increase from 1 to 2 the number of full voting resident members on CCRC boards and increase resident representation on corporate level boards. I wanted to note that Maryland is already leading the way in terms of resident representation. We are one of only 3 states in the nation that require full voting resident members on CCRC boards of directors. Board members of any organization, not just CCRCs, have a fiduciary responsibility to the entire organization, not just one individual consumer or group of consumers. We're not aware of any other private industry that is mandated to have consumers on their board of directors. We support and invite open communication between governance boards and residents and appropriate resident representation on governance boards. However, the proposed changes would limit the ability of CCRCs to operate their boards effectively and in line with governance best practices. For these reasons, I respectfully request an unfavorable report on Senate Bill 76. We look forward to working with the proponents and sponsors to find opportunities for collaboration. Thank you.
So Allison, you're totally opposed. It's not any amendments, it's just the bill completely.
We're opposed, especially to the 2 items that I mentioned. However, we want to work with the proponents and the sponsors to find ways to move forward. We do think that there's opportunities that we can address some of the concerns that have been raised around open communication, education for folks around what's in these contracts and making sure that folks understand. So there are opportunities for us to move forward.
Thank you. And the rest of the.
Hello, Madam Chairwoman, Madam Vice Chair, and members of the committee. My name is Wendy Crampton. I am here today representing Homewood Retirement Centers. We operate 2 CCRCs in Maryland, one in Williamsport and one in Frederick. I too am here in opposition of Senate Bill 76. As Homewood CFO, I object to the proposed changes to the sequence for the return of refundable portion of the entrance fee. As has been mentioned, this change would disrupt our operational and financial model and make it difficult for residents and heirs to understand when their refund would be paid. Our current contract state, your refund payment shall be made to you 30 days after a new resident occupies your residence and pays the applicable entrance fee in full. Our CCRC contracts, which are approved by Maryland Department of Aging, are concise, equitable, and easy to understand. Your refund is dictated by the sale of the sale of your unit. This new bill would confuse this language. In essence, there would be no correlation to whether an entrance fee was collected on your unit. Rather, the refund will be paid when the resident's sequential number has been reached. Hard to sell units would stall the refund process for every single resident in line behind them, instead of just for the resident with the hard to sell unit. Such a change would force the facility to absorb any cash differences between the entrance fee received and the refund paid. Also, we as providers would be forced to increase our rates to our existing residents so that we can build and maintain the cash reserves required every year by the Maryland Department of Aging. For these reasons, I respectfully request an unfavorable report on Senate Bill 76. Thank you for your time.
Good afternoon. Thanks, Madam Chairperson, Vice Chair, and members of the committee for allowing me this time today. My name is Todd Andrews. I serve as the president of our Community Living Division for Asbury Communities. We are proud to serve seniors in 2 CCRCs in Maryland, one in Gaithersburg and one in Solomons Island. Our Gaithersburg campus has served seniors in Montgomery County for over 100 years. We also operate 9 additional CCRCs in 3 other states. I'm here in opposition of Senate Bill 76. Specifically, I will speak to 2 portions of the bill most concerning for operators of CCRCs. CCRC not-for-profit boards are volunteer in nature, and members possess a variety of skill sets and are elected by the full board. The main functions of board are governance, strategic direction, and accountability. Each continuing care retirement community possesses a unique culture with philosophies and policies that support its mission. Therefore, a board must comprise of individuals who make decisions that reflect that mission. Being a resident does not automatically qualify one to serve on this board. There are many factors in identifying and recruiting board members, so the decision should remain with the governing board and not mandated or required participation by anyone. CCRCs operate through a financial framework that is driven carefully structured receipt and refund of entrance fees driven by contract. The agreement between the resident and the community fully outlines and clarifies the terms of the refunds and how they are completed. The proposed bill and its altering its process, issuing entrance fee refunds could place a significant financial burden on the CCRCs, and I believe may threaten the financial investment of current CCRC residents. Put plainly, there's no body of evidence that shows that CCRCs are not returning their entrance fee per the contractual terms in place today. This provision of a bill is proposed to fix a problem that doesn't exist in all CCRCs, and in the meantime, it could create unintended consequences. I respectfully ask for an unfavorable on this bill.
Thank you very much, Madam Chair, members of the committee. For the record, my name is Dana Kaufman. I'm here today on behalf of Lifespan Network. We are also opposed, but as Ms. Sibikowski mentioned, we are willing to sit down and work to try to address some of the concerns raised by the residents. I want to point you, though, to my testimony because I think it's very important to understand a few points. First of all, there's a saying, once you've seen one CCRC, you've seen one CCRC. The CCRCs that we have in Maryland range very differently in size as well as their financial model. There are 3 types of models, and they each provide different services and benefits and costs for their residents. But back in 2012, the legislature passed really a comprehensive bill that was the result of a work group. And in that work group, we did speak extensively about the entrance fee deposits and the refunds. And what we did was ensure that there was adequate and necessary disclosure. So if you take a look at my testimony, you'll see that there are 3 sections that we put into the law to make sure that the residents understood completely what that refund policy was. And the refunds, they change from CCRC to CCRC. There is not one type of refund. It is all subject to that contract. But you will see from my testimony that any type of marketing materials, including our disclosure statements, have to have a very specific statement. Carefully read the continuing care agreement for the conditions that must be satisfied before the provider is required to pay the entrance fee refund. We are required 2 weeks before signing of any contract to provide the resident with the contract and the disclosure. The resident also has to acknowledge that they have read and understood that entrance fee deposit. So at this point, we do feel that the disclosure is there. This is a private contract. We're more than willing to work on other issues, but we request an unfavorable on that. Thank you very much.
Thank you. Do I have questions for this panel? We do not. Thank you very much. We have one virtual witness, Dan Tracy, favorable, I think.
Yes, good afternoon. My name is Dan Tracy. I'm president of the MACRA chapter of the Mercy Ridge Retirement Community in Timonium, Maryland, so testifying in support of Senate Bill 76. A continuing care retirement community, a CCRC, is a unique entity given the status of the residents. Practically, it's like a cooperative corporation where the residents make a substantial upfront investment and long-term commitment for an exclusive residential unit. But legally, the CCRC is not like a cooperative because the residents do not have any voting rights, despite the fact that they're the principal beneficiaries of the enterprise, the reason for its existence. The CCRC residents are seniors who have made investments and commitments essentially for the rest of their lives and relies upon an extensive array of representations and promises made to them by the CCRC entity. Consequently, it's a matter of basic equity that the residents have some meaningful participation in the policies and operations of the CCRC. Now, current law on resident input simply provides that the management board elect one resident to serve on the board. That's it. Additionally, the single resident board member has been of minimal benefit since he or she's been muzzled by an unnecessarily restrictive view of fiduciary obligations, preventing them from discussing any board governance matters with the residents, not just confidential matters. There's no reason why a resident board member cannot discuss non-confidential corporate matters directly with residents and non-resident and the resident association and still faithfully maintain his or her fiduciary obligations to the corporation. What MACRA is proposing in the first part of our bill is a relatively modest enhancement of the resident input provisions of Maryland's law, which we will believe will not only make their participation more effective, but in providing for greater transparency, it will also help discourage the we against them mentality prevalent in many, if not most, of our communities. We thank you for your support.
Thank you very much for your testimony. Do I have any questions for this witness? No. There, you're finally there. You weren't there the whole time you were speaking, but
Sorry
thank you,
about
Mr. Tracy. That's okay. Thank you. Thank you very much. And that will end the hearing for Senate Bill 76. Our next bill is Senate Bill 201, and Senator Watson is here. And you don't have a panel, do you, Senator Watson? It's just you.
No, I have two folks.
You do?
Yes.
Okay, they're not signed up. You have to introduce them. I have a virtual person. Jana Parker is.
Oh, she's virtual. Okay,
Okay,
that's
thank
great.
you. But she's not in right now. Okay, thank you.
All right. So good afternoon, Madam Chair, Vice Chair, members of this committee. Senator Watson here to ask your support for Senate Bill 201. This is the same bill that I presented last year, and there is an amendment that I'll discuss momentarily. But once again, this bill is quite simple. It simply is used to establish the paternity and strengthen families. Recognizing that fatherhood is a vital component in raising our children, this bill simply says, at the moment of childbirth in a healthcare facility, the attending physician offers a paternity test to the presumed father. That's it. There is no cost. The presumed father can waive the test, but they can take the test. Now, why do we want to do this? State of the Maryland Families. This came out very recently and will show you that especially in the Black communities, Prince George's and Baltimore City specifically, there are a larger number of single parents than any place else, and those where our kids are hurting the most. Carnegie Mellon study has shown that the sooner a father knows that they have a child, the more likely they are to be involved in that child's life. I found it absolutely appalling for many, many years to look at TVs and see Black families exploited on Jenny Jones and some of these other shows that will have a father and a mother with three men, and they want to establish paternity on TV to get ratings. I found that very disrespectful to my race and disrespectful to families in general. And so that's what this bill does. But in talking to residents in my community who are very supportive, and this happens more often than not, than you think, I did express to you all last year presenting this bill that I myself paid child support for 10 years. And it wasn't until my daughter, and I call her my daughter today, came down with lupus, that a paternity test was done and found out that I was not the child's father. That was traumatic to my family, traumatic to my mother. These were family bonds that were built on a lie. Now, this is not to say that women are bad or mischievous, as some of the testimony that I saw submitted. This is simply saying a father has the right to know that they have a child walking on this earth, period. And the sooner they know, the better the outcome is for that child. The amendment basically says, and we do recognize that when a paternity test is given, the results come back usually within 2 to 5 days. The amendment says, if the paternity test confirms that the presumed father is the father of the child, the healthcare facility shall notify the father and mother of the child of the test results by telephone or email. It also says, if the paternity test excludes the presumed father as the father of the child, the healthcare facility shall contact the presumed father and mother of the child separately to schedule a time to separately provide the results in person through a licensed counselor at the healthcare facility. That's very important because when a parent finds out that they are not the child and things were based on some falsehood, it can be very, very traumatic. And as Ms. Parker, who will testify shortly, she will tell you about these things because she helped me craft the amendment to this bill. So in closing, I just want to say, I ask your support for this. No, it doesn't cover all circumstances. If a child is born, at home or in another facility or in another country or in some kind of means of conveyance on an airplane and those types of things. That gets beside the point. Let's establish a baseline that says in a healthcare facility, the presumed father is simply offered the paternity test, just like being read the Miranda rights. It's a right that the parent already has. But when you're young, like I was, and you find out that you're going to be a father, it can be very emotional and it can be very challenging. And you're being pulled from one side to another, from parents, from grandparents, and it's quite confusing. But to simply say, you want to be sure before you bring your whole family to come around and create these bonds that can unfortunately be broken down the road. I lived through it, so it's very traumatic. So with that, Madam Chair, I'll ask any questions, but I'd like for my witness to say some words.
Would you like to wait? Senator Watson has a question. Would you like to hear from your witness before the question?
I'd like to hear from the witness first.
Okay, and I have a question for you. We don't
Sure.
have the amendment. You talked about this amendment. We don't have it in the bill file.
You don't have it? Okay.
Thank you.
Thank you. Thank you, Finance Committee. My name is Jana Parker. I am a resident of Prince George's County, and I'm speaking in support of this bill. And I appreciate Senator Watson for putting the amendment that was requested to be put in. This bill for me is simply about protecting families on all levels, emotionally, physically, and health-wise. When there is a presumption that the father is the father of a child, a lot of things come into capacity when you think about the health of that child, family history in regards to health, what are the backgrounds in regards to both of those families. And what you don't want, and what I've seen, unfortunately, is families that presume that the father is the father of that child, and there is a life-threatening medical emergency. And that is the moment in where they find that this is not the father of the child, and how that not only impacts the family at a most crucial and vulnerable time, but also continues to put a life in jeopardy. So this just offers people the chance from the onset to just know who is the father of the child in regards from that perspective of a physical health standard, and then also from the standard of an emotional health, right? As Senator Watson pointed out before, it can be traumatic to all parts of the family, the child, the presumed father, the mother, the extended family, to build a bond with children and then find out that that is not their child. And then subsequently, those family bonds are torn apart. The support is torn apart. Those sorts of things are just left out in the wind. And it's very important to know from jump who and what should be supporting the child in all capacities. If someone wanted to move forward to support a child that is not theirs, they should know at the beginning and at the onset of that life, so that they can have all the information to make the appropriate choices. For me, it's not about saying that someone is lying or not trusting women as much as it is about putting everyone in I'll just finish my sentence, putting everybody in the best possible situation to understand how to move forward to best support the child for the remainder of their life.
Thank you, Ms. Parker. And now we have the question from Senator Washington.
Thank you, Madam Chair. My question is for you, Senator Watson.
Yes, sir.
Define presumed father. It's not defined in this bill.
I can define it for you.
Well, it's not defined.
But let me tell you what it is.
Is it defined in the statute somewhere? Where is it?
I'd have to go back and check.
So there's no definition for presumed father. So anyone can essentially come in and say, I'm the father of this child. You shall read me, as in your words, Miranda rights.
If the mother, who we know is the mother, brings a gentleman in and that gentleman says he's the father, then, they can waive the rights to have the test. That is the
Can't they already
presumed,
do that?
that is the presumed father.
Can't they already do that?
Of course. This
So
is
the-
saying they get,
We-
they get notified. This is about notification.
No, it's about you, well, first off, you don't define what presumed father is, and that's in this legislation. And anyone can say, and it doesn't say that the mother has to approve it either. It just says that you are the presumed father. The presumed father, I can presume myself to be the father of this child, and then I have to take a DNA test, and that child can be swabbed without the consent of the mother. Is that right? Under this bill?
Yes. That's
Without
right.
the consent of the mother?
That's right. That's right.
And why is that okay? Without the consent of the mother of her known child?
No, she knows it's her child.
Correct.
Mama's baby, daddy's maybe. The father doesn't know. The father may not know. You don't know what goes on in households. You just don't understand. The father, the presumed father, has the ability to waive the rights. It may not be the actual biological father.
So
It may
so
be
you-
someone
so
else
under this
who
legislation,
wants to take that responsibility.
under this legislation, Senator, you want to allow a random person that's undefined, that has not been approved by the mother, that single mother at that moment, to come in and say, I'm the presumed father. I want that baby to be swabbed and make sure that I'm the father of that child.
Well, let's put it like this. The presumed father is a person identified by the mother.
I have a lot of angst about this bill personally, because I was raised and born of a single mother who did not want want my father to contact me at all, for lots of reasons why.
And you think that's a practice that needs to be promulgated?
From where I am sitting, yes. It's up to that mother.
I appreciate your.
I do believe that.
I appreciate your.
And I know you said this bill isn't supposed to be offensive to women. It's offensive to me as a son of a single mother.
Giving someone the right that they
no,
already
you're
have.
not giving them the right. You're telling the physician that's there that they should read Miranda rights, in your words, to a presumed father of a random person that's out there. That's not defined.
I don't agree with the random person, but the other parts of your question, absolutely. It's the right of the presumed father to know that they have a child, period.
Of which we don't know what a presumed father is.
I'll tell you.
Thank you.
Give me some time.
If I may, as I am Senator Watson's witness, just to make a comment on that, as I understand it, the presumed father could also be a part of a marriage, because under the law, the someone who is married to a woman, they are presumed to be the father automatically, and subsequently this would
Anna,
apply to
I'm
them
sorry,
as well.
I'm going to cut you off. Senator Washington asked the question of Senator Watson.
Okay, that's fair.
Senator Kyle, do you have a question?
Yeah, I just had a comment with respect. Thank you, Senator Watson, for this bill.
Thanks.
But I think what I was going to say was actually what the witness was going to say, that it's my understanding that actually under Maryland law, a presumed father is the individual who is married. There's a presumption of paternity when the child is born of a mother who is married to that father, or that individual. Whoever is married to that woman is presumed to be the father. So
That's in Maryland law.
yeah,
Right.
that's in Maryland law.
Yep.
That's exactly what Maryland law is right now. So this is merely a comment, not so much necessarily a question. I just wonder if maybe the way that is that your intent for this bill, is to say that the person that's married to that mother that would do the paternity test, or is it your intent that somebody who's there at the hospital when the baby's born to be considered? Because I just think that with the way you may have it contemplated for the definition of presumed father may actually be counter to what Maryland law is on the presumption of paternity.
And I appreciate that, Senator Gao. And you raise a good point. The issue at hand, and what I'm trying to grapple with, is that there is, on a regular basis, fathers who think they're fathers and not. There have been cases, and everybody will agree, there have been cases where there have been a married couple, and then the father finds out that they're not the father. But I don't want to touch that. I don't want to deal with that statute. If you're married, you have a child, you're the father. What I want to get at is these, when the couple is unmarried and they go in and have a child and that presumed father is offered a test. The reason I want to do that is because all the statistics that I've seen from Maryland families show that particularly the structure of Black families has totally disintegrated. We have the highest number of single parent families, and there is a correlation between that, educational success, and a bunch of other things. And I want to fix that. And I rarely hear anyone talking about bringing Black families together. I rarely hear anyone championing what Black men and Black fathers need to do. And so I'm speaking from the voice of many people in my community. Granted, I probably should go back and make sure what that definition is of presumed father. I think that's an easy fix. But I want this body, and I brought this before, and I'll bring it again and again, because I think this is an important right. The issues that we talk about with education, the money we're spending all over the places, if you rectify the family first, a lot of these problems will be resolved or mitigated. And that's my belief.
Thank you, Senator Watson. I agree. It's a noble cause. Thank you.
Thank you.
Thank you, Madam Chair.
Do I have any other questions for the senator or our panel?
It's never.
Oh, another question, Senator Washington. I'm sorry.
Yes, thank you, Madam Chair. Again, presumed father is defined somewhere in law, and I appreciate Senator Gao. Again, this bill doesn't say much about the right of the mother at all. What the mother's rights are in this paternal test, it does not mention that. And I wanted to be clear that this bill will not help bring Black families together. This bill singly does not do that. And as a person who was raised by a Black single mother, I know firsthand she worked her butt off to make sure that I was successful. And the rest of us, the 6 and 7 kids that she raised, made sure we were all successful. And so to say that this is gonna help Black families, I think it's wrong.
I'll provide
There's
you some statistics.
other measures and ways to do it.
I'll give you
This
some
is
info.
not it.
I'll give you some info.
Thank you, Senator. I don't see any other questions. This hearing is over. Thank you, Senator Washington.
Thank you.
And
Thank you.
Senator Watson. The next bill is Senate Bill 59, Safe Sleep for Infants, and Senator Ellis is the sponsor. Are you bringing any panel up with you, Senator Ellis? No, he might be bringing. Can you tell me who you're bringing up, please?
Yeah, thank you, Madam Chair. Dr. Rachel Sherman, Dr. Yvonne Ronner, Ms. Mohammed, and Ms. Katanta Kels.
Okay, great. Thank
Is
you.
that okay?
Yes,
The
sir.
floor is
Get
good?
started.
Take a seat. Good afternoon, Madam Chair Bado and Vice Chair Klossmeyer, members of the Finance Committee. Senator Arthur Ellis, District 28, Charles County, here to present Senate Bill 59, a matter of most importance, statewide standardization of safe sleep practices for our youngest and most vulnerable members of our society, infants. Safe sleep. The purpose of Senate Bill 59, Safe Sleep for Infants, Awareness and Certification, is to require the Maryland Department of Health to develop and implement a public awareness campaign to promote education regarding safe sleep for infants. Establish the Maryland Safe Sleep Certification Program, require child care centers to be certified by the program, and require hospitals and freestanding birthing centers to be certified by the Cribs for Kids National Safe Sleep Hospital Certification Program. Sudden unexpected infant death is a term used to describe the sudden and unexpected death of a baby less than 1 year old, which the cause was not obvious before investigation. And that's a Centers for Disease and Control and Prevention, CDC, term. Such death may occur during sleep or in a baby's sleep area. 3 commonly reported types of sudden unexpected infant death include sudden infant death syndrome, SIDS, unknown cause, accidental suffocation and strangulation in bed. All those contribute to the problem. In Maryland, as in every corner of the globe, ensuring the safety and well-being of our children is not just a priority, but a moral imperative. As proposed in Senate Bill 59, this bill, the Maryland Department of Health, in collaboration with the Department of Human Services and Cribs for Kids, has 4 major provisions. Safe sleep certification requirement requiring all birthing hospitals and child care centers in Maryland to obtain and maintain safe sleep certification from a recognized authority, ensuring compliance with approved safe sleep guidelines and practices aligned with both the National Institute of Health and the Safe Child Care licensing laws. Also need to promote education and training and require monitoring compliance, public awareness campaign development, managed through the Maryland Department of Health. By mandating safe sleep practices and educating healthcare professionals, parents, and caregivers, this legislation aims to significantly reduce the incidence of sleep-related infant deaths and create a safer environment for Maryland's infants. So why is this legislation needed? Let's share some numbers. I'm a numbers person, if I may. In the year 2020, 393 infants died in Maryland. This data represents 5.7% per 5.7 per 1,000 live births. Of the 393 infants' deaths, Maryland Vice Statistics Administration reported the ethnicity is white 103, African American, Black 196, Hispanic 63, and other races 28. So in that 1 year alone, last year we have full data for back in 2020, 393 infants passed away because of the sudden death. Despite advances in medical knowledge and public health efforts, sudden infant deaths continue to be a leading cause of death among infants aged 1 month to 1 year. In 2016, a 4-month-old baby named Breland died at the Little Angels Daycare from sudden infant death syndrome. The daycare provider lost her license to operate in Maryland. Unfortunately, for Summer Portia Burke and her husband, David, of College Park, Maryland, their child did not make it out of that daycare. In another disturbing instance, a 6-month-old infant, Millie, died on April 22, 2016 after reported choking while asleep and being physically abused while at the Little Dreamers daycare in Rockville. The owner was sentenced to 40 years in prison. Safe Sleep Certification Program will help hospital systems who vary in high quality labor and delivery services. Believe it or not, not all of our 32 birthing hospitals in Maryland meet the federal criteria for employing birthing friendly practices in Maryland. That means a lot of babies are being born in hospitals that don't have a clue how to have safe sleep for these babies. In fact, not all of Maryland hospitals are equitable with its National Intensive Care Unit and Trauma Center designation or advanced maternal health care. The National Safe Sleep Hospital Certification Program provides evidence-based policies and consultation for implementing safe sleep criteria for hospitals and hospital systems of care. In Maryland, there are 4 hospitals that earn a Safe Sleep Hospital certification from the National Safe Sleep Hospital Certification Program. So let me say again, in Maryland, 4 hospitals have earned Safe Sleep designation out of 32 birthing hospitals. 4 out of 32. Question is, why don't they all know how to have safe sleep practices when the certification, the training is out there, and when you have in 2020 363 infants dying through birthing process. In closing, committee members, beyond the immeasurable emotional toll, sudden infant death impose significant economic costs to families, communities, and the healthcare system. Invested in preventive measures, education, and support services for families can yield substantial long-term savings while safeguarding the lives of our infants. Consideration may be given to leverage the Maryland Prenatal and Infant Health Care Grant Fund. Implementing safe sleep certification for birthing hospitals in Maryland is a proactive measure to combat infant mortality and improve infant safety. The proposed legislation sets foundation for a holistic approach toward infant safety, ensuring a brighter and healthier future for the state's youngest population. Thank you, Madam Chair and Vice Chair, members of the committee, and I hope to have a favorable report for Senate Bill 59.
Thank you. Good afternoon, Chair, Vice Chair, and committee members. My name is Dr. Rachel Sherman. I am a board-certified family nurse practitioner, an Army veteran, a mother of two, and I also provide care for the newborn service at a hospital in Prince George's County. I'm here today in support of Senate Bill 59. Despite major efforts to educate and implement safe sleep practices across the United States, sudden infant death syndrome increased 15% from 2019 to 2020. Sudden infant death syndrome is the third leading cause of infant death in the United States. And in 2023, sudden infant death syndrome accounted for 38.4 deaths out of 100,000 live births. As a mother and a healthcare practitioner, these are startling statistics. I wish that I could testify today only having textbook knowledge of SIDS, but I have personally been impacted. I lost a cousin in 1987 due to sudden infant death syndrome. And I can tell you that the long-lasting implications and impact on my family are still an area of concern for us today. This bill further strengthens the infrastructure needed to ensure the safety and welfare of Maryland's most vulnerable populations, infants. We know that safe sleep protocols and practices update due to ongoing research and data collection. So enacting such a bill will not only ensure that childcare and healthcare facilities seek safe sleep certification, but that they also maintain it. And maintaining the certification ensures that providers and facilities stay current with the latest evidence-based practices to prevent unexpected loss of life. Protecting life is a priority, so I ask for a favorable report on this bill. Thank you.
Good afternoon, Madam Chair, our bill sponsor, the Honorable Senator, and members of the committee. My name is Mujahid Muhammad. I am a licensed clinical social worker in Maryland, a commissioner on Baltimore City School Board, and I am a strong yes in support of SB 0059. Comprehensive and systematic coordinated safe sleep practices coupled with education and targeted interventions using adequate data and sensible measurable outcomes are effective ways to reduce sudden infant death syndrome. High literacy rates, particularly, have been linked to better outcomes in communities where literacy is high. Infant mortality rates tend to be significant, where infant mortality rates tend to be significantly lower. According to the United States Department of Education, only 12% of US adults have proficient literacy education. In 2021, Maryland ranked 17th in the nation regarding infant mortality rates with 5.9 per 1,000. High literacy rate, our health literacy rates isn't a disease. It is the difficulty experienced by all races and ethnic groups to find health information and practice them within their homes. I'm here today as a support to show the partnership willing by your state agencies, school systems, and community organizations to partner within this bill. Maryland needs policies that support safe sleep and build education regarding our most vulnerable population, Maryland babies. Thank you.
Madam Chair,
and co-chair in the Finance Committee. My name is Yvonne Bronner, and I am a professor at Morgan State University with a long history in maternal and child health. And I am here today in support of Senate Bill 59, submitted by the Honorable Senator Arthur Ellis. Safe sleep for infants and awareness and certification. I am going to stress the safe sleep education component of this. There are 5 components, and those have been mentioned. And one will require Maryland Department of Health to develop and implement a public awareness campaign to promote education regarding safe sleep for infants. And so why is this important? This is important because, as has already been stated, infants are dying, and that impact on families is traumatic. And so what we want to do is help people better understand that there are some very simple steps that they can take to prevent this. As a matter of fact, a lot of the deaths are preventable. And so the American Academy of Pediatrics back in the 90s, based on evidence, was able to say that there are these 4 elements that a lot of people know, the ABCDs of safe sleep. Alone on the back in the crib and not smoking. And that these are updated as new evidence becomes available. It has also been stated that there is the huge disparity, like in many other cases, that African-American infants are dying at 2 to 3 times the rate. Now, what can we do about this? This safe sleep campaign that I am really the element of this that I'm supporting. Certification has already been mentioned, but what I want to speak about is some research that I've done with the state of Maryland over the last 5 years, where we have engaged community health workers and doulas and other people who can assist parents in the education process. And so I just want to be fully supportive of this bill and the education element. Thank you.
Good afternoon, Chair and members of the committee. My name is Keontae Cowles. I'm the Public Policy Manager for Family League of Baltimore, and I'm here in support of Senate Bill 59. Family League serves as an implementing partner in Be More for Healthy Babies, a collective strategy aimed at addressing infant mortality while further closing the disparity gaps in birth outcomes. In alignment with BHB, to ensure that babies are born healthy, we support legislation that raises the critical awareness of safe sleep for infants. Sleep-related deaths is one of the leading causes of post-neonatal mortality, which is why it is important to provide education and certification to Baltimoreans and Marylanders alike. Unfortunately, the city of Baltimore has seen an increase in the number of sleep-related deaths since the pandemic. In 2023, there was a total of 18, which is the same amount from 2022. Care coordination also plays a crucial role in connecting pregnant and postpartum individuals to resources, spreading the message about safe sleep in communities, and providing families with a safe sleep environment for their infant. As the designated local management board for the city of Baltimore, Family League works collaboratively to support data-informed, community-driven solutions to align resources to dismantle systemic barriers that limit the possibilities for children, families, and communities. Our policy focus is also guided by and in support of the Governor's Office of Children Results for Child Wellbeing. In closing, we support Senate Bill 59 in particular because of its alignment with the result area that works to ensure babies are born healthy. Thank you for your time.
Thank you to this panel. Do we have any questions? Thank you very much. I have 3 people that are favorable with amendments. Christina Push, Jane Cranky, and Pam Casemeyer.
Good afternoon. I'm Christina Push. Thank you, Chair and Vice Chair, and thank you for your leadership, Senator Ellis, and for bringing this important topic forward in Senate Bill 59. I'm Christina Push, Executive Director of the Maryland State Child Care Association, Office of Child Care Advisory Council Co-Chair. And MSCCA represents over 5,000 child care providers and over 400 programs. and also as the co-chair of the Office of Child Care Advisory Council, which directly advises and reviews COMAR regulations for childcare. We agree with Senator Ellis that safety is the highest priority and a strong foundation for licensed regulated childcare settings. And in Maryland, our state boasts some of the strictest regulations in the country. MSCCA supports Senate Bill 59, however, offer multiple amendments enumerated in my written testimony and shared with the sponsor for his consideration. We are excited and supportive of the Maryland Health Department developing the public awareness campaign for safe sleep practices referenced in this bill to help expand awareness and educate parents and caregivers. MSCCA does not support the requirement of certification in Maryland's Safe Sleep Program for childcare centers, as this effort is duplicative. Maryland State Department of Education Office of Child Care COMAR regs include safe sleep practices, which align with and exceeds the Maryland Safe Sleep Certification Program. This bill does also, in reference to the testimony we heard, does not include registered and licensed family child care programs, which are over 5,000 of those in the state and care for over 12,000 children, and they are exempt in this legislation. So it should be inclusive of everyone, which COMAR is. So MSCCA recommends partnering, that MSD partners with the Department of, Maryland Health Department as the licensing authority for childcare to review and create alignment of the current regulations and the training practices with Maryland Safe Sleep to avoid unnecessary and duplicative efforts outlined in this bill. And we recommend amending the language around compliance and evaluation of programs for certification to an equivalency determined by the licensing authority at MSDE. And we finally respectfully ask you to strike all the threatening language related to fines and civil citations, as we are we lack insufficient space for toddlers, infants and toddlers. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Jane Grinke. I'm here on behalf of the Maryland Hospital Association and our member hospitals and health systems. Excuse me. We support the goals of Senate Bill 59 and appreciate Senator Ellis bringing this forward. We acknowledge the life-saving role that safe sleep practices have in preventing infant mortality. And we think that similarly, that a public awareness campaign could be very effective. You know, we think it's important to have the same message throughout the healthcare continuum and throughout the stages of pregnancy, before, during, and after. And we should all be saying the same thing to reinforce the messaging. And additionally, the Kids for Cribs designation is a model program. However, we are concerned about mandating that hospitals apply for a specific designation, especially for an entity that's not connected to a state or federal entity. So it could, in theory, hopefully it won't, it could go away. It's not a permanent structure. And many Maryland hospitals have applied. I know you noted 4 already have the designation. I know of several that are thinking about applying. But we are just concerned about a mandate. We have been working with Delegate Lewis in the Baltimore City Health Department across the street on a safe sleep bill. We testified on it yesterday. We worked with them to create amendments. So that bill mandates that hospitals provide safe sleep education at discharge, which we think it's a practice that hospitals are doing, but having it in law would ensure uniformity. Senator McCray has a cross file that we plan to support as well. We think that public awareness campaign could really add to that bill, again, just spreading the message. We are happy to be part of the solution in reducing preventable infant deaths from unsafe sleep environments. We think no child should die in that way. We appreciate, again, the senator bringing this forward, and we ask for a favorable report. Included our amendments. We'd like to strike section 19.310.4 that just mandates the certification for hospitals. Thank you for your time.
I don't see any other questions. I do have a question. Jane, is it your understanding now that as mothers and babies are released from the hospital, that they're given information on the safe sleep?
Yes.
Is that do you think that's true of all of our hospitals in Maryland?
Yes, it just varies in the form. Some have, the Baltimore City hospitals have a great partner in the health department, so they have instructional videos and robust brochures. Some hospitals might just say it verbally. Most have them sign something. It just varies because there is not a standard process. But that is a best practice with the American Academy of Pediatrics, and so that is provided.
Thank you. Do I have any other questions for this panel? Thank you for your testimony. And that ends the hearing on Senate Bill 59. And next we have Senate Bill 197, our Senator Ellis again. This is Residential Service Agencies Reimbursement of Personal Assistance Services. And do you have a panel, Senator Ellis?
Yes, yes, Madam Chair. Mr. Rodwin, I think Medicaid Director Ryan Moran had multiple hearing, so I don't think is he here? No? Okay. And Deputy Secretary Jenna Crawley of the Department Agent.
Thank you. There's, wait a minute, I missed somebody. David Rodwin, Jennifer Crawley, and the person in the middle. What's your name?
And Daria Wiley. Got it right? Nadia? Okay, thank you.
Thank you.
Good afternoon again, Madam Chair and Vice Chair and members of the committee. I'm here today to present Senate Bill 197, Residential Service Agencies, Reimbursement and Personal Assistance Services. The purpose of this bill is to authorize the Maryland Department of Health to reimburse the Residential Service Agency for personal assistance services only if the personal assistance services are provided by an individual classified as an employee. Maryland has a home care workforce crisis. Unfortunately, the quality of home care jobs are very poor. As a result, our state does not have enough home care workers to meet the growing need for them. And worker turnover is off the charts, which makes life much harder for people who rely on caregivers to stay in their homes. Part of the reason for this crisis is that many home care workers are misclassified as independent contractors by the agencies that employ them. Let me say again, many of home healthcare workers are misclassified as independent contractors. Why is that a problem? Well, it saddles the workers with a much higher tax burden when they are supposedly self-employed. Imagine that they are enticed, they will pay you $20 an hour, and you're an independent contractor, you're making so much more than an employee. And these folks say, oh, great. And then a few years later, IRS do an audit and say, hey, I know you're making money because you're paying your rent, you're paying all your utility bills. We calculate you made, say, $100,000 over 5 years. So pay us the tax, not just the employment tax, but you're looking at the self-employment tax, which is the Medicaid, the Social Security contribution, and all those other taxes. And they're saddled with a bill that could be $25,000, $30,000 plus penalties and interest, because these folks are generally not individuals with advanced degrees or CPA certificates, and they don't have a clue, and they're here hit with this huge tax bill. So they're being taken advantage of. They don't understand that bigger hourly wage has a lot of consequences, and they are hurt tremendously by this. And chances are they will not stay in that industry, and they continue to cause crisis with availability of employees or workers for this industry. So this bill is a win-win for everyone and has no fiscal note, and the Department of Health supports it. So there's advocates for workers, seniors, people with disabilities, as well as many home care agencies themselves who face unfair competition from agencies that save money by breaking the law. Yeah, misclassification of these employees is breaking the law. It's not something that is allowed. In short, this bill is about taking steps to solve Maryland's home care workforce crisis while also making sure that Maryland's Medicaid dollars are used appropriately. It's a simple fix to a serious problem. So the fix is anyone who applies to Medicaid for payment, they have to be employees and not independent contractors. Simple fix, and we hope with a simple fix, we will take care of a serious problem. So thank you, Madam Chair, Vice Chair, and members of the committee. And I urge a favorable report on Senate Bill, what's the number? 197, last bill of the day. Thank you.
Good afternoon, Madam Chair Vital, Madam Vice Chair Klausmeyer. My name is David Rodwin, and I lead the Workplace Justice Project at the Public Justice Center here in support of SB 197. And thank you to Senator Ellis for sponsoring the bill. Misclassification of home care workers as independent contractors is a really, really serious problem for all the reasons the senator articulated. In addition to facing higher tax burdens, which these workers cannot pay, many of our clients simply don't file taxes because they don't have the money to pay the IRS. These workers lose workers' compensation protections, which is a huge problem in this industry because of all the injuries in this work, unemployment insurance, paid sick leave, minimum wage and overtime protections, the list goes on. Independent contractor misclassification is also called workplace fraud. Governor Moore just signed an executive order on this about 3 weeks ago, establishing a joint task force on workplace fraud and highlighting the problems that result, not just for the workers, but also for businesses that follow the law and for the state of Maryland, which loses out on important tax revenue. This bill has a lot of support: consumer advocates, worker advocates, folks in industry, legal experts, the Department of Health, the Department of Aging. There's really an extraordinary amount of support on it. I also just want to note two additional things. One is there's a delayed effective date. The effective date on the bill is not till October 1st, 2025. It gives that extra time, which we negotiated last year with the Department of Health, for any agencies to get into compliance. So it won't just be a shock out of the blue for anyone. Second, what this bill does not cover. This bill only covers certain Medicaid programs under the Office of Long-Term Services and Supports. It doesn't cover DDA care. It doesn't cover private pay or insurance. So anyone who's paying out of pocket, this bill does not affect them. Nursing referral agencies, this bill does not affect them in the slightest. It's only those Medicaid programs under the Office of Long-Term Services and Supports, because there's existing guidance making clear that these workers are employees 100% of the time. With that, we ask for a favorable report. Thank you so much.
Thank you. My name is Nadira Wiley. I live in Baltimore City, and I've been a home care worker on and off for over 30 years. I love my job because I believe that care is what keeps this world afloat. I'm here today because just last month, I realized that my agency that I work for classified me as a 1099 self-employed worker. I recently got into a serious car accident that has left me without a vehicle, and I feel PTSD. And I use my vehicle to take me back and forth for my clients, my patients. But I do not have health insurance through my job, nor do I have sick leave. I've had no idea that for the past 5 years, I could have had these benefits if I had been misclassified by my employer, if I had not been misclassified. I'm here to protect the thousands of other home care workers in my state working for residential services agencies, working underpaid and without the benefits they deserve, and like me, may not even know. For too long, home care workers have been invisible to society as we travel to people's homes, ensuring that they can do their daily tasks safely and with support. I'm here today to fight for home care workers in the state, but also for my patients who deserve consistent caregivers. Because of low pay, I have colleagues jumping between agencies or sometimes leaving the field entirely to earn money more than another industry. I do this work because providing care is personal to me, but I am underpaid and burnt out trying to make ends meet for me and my family. The work that I do is emotional labor, but it also directly impacts my physical health as I go into people's homes during this pandemic and when the condition of people's homes are unsafe. I also had a brain tumor and I suffered a stroke, 2 strokes exactly. And I've had 2 brain surgeries. I suffered paralysis, and when I could not walk, talk, or barely eat, I relied on a friend to care for me. Legislators, would you please consider what I'm saying to you, because one day it may happen to you or one of your loved ones. Spirits are health inclined. Thank you for letting me share. Forgive me.
Thank you to this panel. Ms. Wiley, thank you for your story. I think it really highlights the seriousness of healthcare workers not being employees. So thank you for that. Do we have one more? You have one more to speak?
Yes. Good afternoon. Thank you, Chair Beidel, Vice Chair Klossmeyer, and members of the committee. My name is Jenna Crowley. I have the honor to serve as the Deputy Secretary of the Maryland Department of Aging, and in previous professional roles, notably as a community-based social worker, working alongside direct care workers such as Ms. Nadira over here, and really ensuring service for people who desired to age in community with support. I'm pleased to be here representing the Department of Aging in support of SB 197, the Home Care Worker Rights Act. We thank Senator Ellis for bringing this important legislation forward. You have our written testimony, so I will highlight a few key points. Marylanders are living longer lives. Just as Secretary Roque spoke to this earlier, the Department of Aging recently had an executive order signed by Governor Moore launching the Longevity Ready Maryland initiative. I'm here today because an essential component of being longevity ready is a thriving home care sector and workforce. Home care workers are the backbone of aging in the community and absolutely vital to our care infrastructure for Maryland's older adults and caregivers. These critical workers ensure people who require assistance with activities like bathing and dressing and preparing meals, often on limited incomes, remain living in their homes and promote independence and choice outside of more expensive care settings like nursing facilities. Maintaining the status quo harms misclassified home care workers who lose out on valuable job benefits. Maintaining the status quo harms people who are seeking home care assistance and those home care agencies that receive Medicaid funds that are classifying their workers appropriately under existing state guidance. Maryland's overall economic competitiveness and longevity readiness depends on this. For these reasons, we urge you a favorable report on SB 197. Thank you for your considerations.
Thank you very much. Do I have any questions for this panel? Thank you for your testimony. Allison Yunda, Tammy Bresnahan, Matthew Allman, Jason Haffer, Zinovieve Fradlin. Did Ryan Moran come in? Ryan, you want to come up? Thank you. Someone can start when you're ready.
Good afternoon, Madam Chair and Madam Vice Chair and members of the Senate Finance Committee. My name is Matt Allman. I am an owner and the CEO of a company called Home Centris Healthcare, which is an RSA in Maryland. We have 5 offices throughout Maryland and we employ about 1,300 caregivers. We are one of the largest providers of Medicaid services in the state of Maryland. And of those 1,300 employees, we have full-time employees, we have part-time employees, we have employees who are family members caring for another family member, some of which actually live in the client's home with them. I'm also a board member of MINCA, which is the trade association for home care in the state of Maryland. I'm testifying in favor of SB 197 today. And I'd like to open my remarks by referencing the guidance document that the General Assembly asked for in 2021 and was published in 2022 by the Maryland Department of Labor, the Attorney General, and the Department of Health. And I've attached it to my testimony that I uploaded yesterday. The first sentence reads, Maryland RSAs sometimes wrongly classify PCAs, that is anyone paid to provide personal care services, as independent contractors rather than employees. When this happens, it's called worker misclassification and it is illegal. And that is the first sentence of that document. In addition, the Federal Department of Labor issued some clarification in its final rule on December 9th of this year, and they issued 9 tests, on the 9th. They have 6 tests in their rule that make it very clear that the caregivers that we use in our industry are employees, not independent contractors. So I am testifying in favor of this today. Well, so why does this matter? The first reason it matters is it will provide the legal protections that the General Assembly intended to provide to Maryland's workers. I can tell you that, oh my gosh, okay. All right.
There may be questions later.
All right.
Thank you. Next.
Well, I'll try my best to pick up where Matt left off. My name is Jason Hafer, and I work alongside Matt at Home Centris Healthcare here in Maryland, serving, as he mentioned, 1,000 consumers with 1,300 caregivers across the state. And I would like to address not only all of the labor protections that workers realize when they're appropriately classified as employees, but some of the objections that you're likely going to hear a little bit later on in some of the discussion today. Home Centris is an organization that at one time in its history utilized 1099 caregivers as opposed to W-2 employees. After consideration, evaluation, about 7 years ago, we made a transition, and we did it for a lot of reasons. The main reason was it's just the right thing to do. It wasn't because it was easy, because it wasn't, and it cost us money. But it was the right thing for us to do for our employees, for our caregivers, and ultimately for the consumers and families that we serve. And it made sense. It makes sense because it's legal. It's the right way to classify people. This ensures that no healthcare workers left behind, that they receive the protections, the classifications that they deserve, that they get the overtime pay, the workers' compensation, the unemployment that everybody talks about. But also it protects the consumer, because the consumer is insured an appropriately trained caregiver, somebody who's going to have appropriate backup, reliable backup, that they're going to be working with an agency and with an individual that is appropriately supervised by an agency and trained. And so there's just a lot of protections involved in this bill and in appropriately classifying individuals. And I will say that the delayed implementation is, I think, a big piece of why this bill can be successful. We converted over 1,000 caregivers in about 6 months back in 2017 or so. So I know that other organizations can do the same thing in the time frame that's provided, and I'm happy to answer any questions about what that looks like and how that impacts an organization if time allows questions a little bit later on. But that's why we urge a favorable support of this bill. Thank you.
So I'm sorry, my name is Novi Frodin. I represent Home Care of Baltimore, and because I cannot talk so fast like my neighbor, I'm asking for 1 minute extra, if you can give it to me. Okay, if you will give it to me. Now, I'm in business with company for 13 years, and we initially structure our company as 1099. In a few years, we start facing a problem. We had few audits from government agency. The first one was conducted by unemployment department, and they determined that our 1099 employee, we consider it is wrong, it should be W-2 employee, and results in penalty. In couple months, the follow-up was audit from labor department, and result is the same, penalty. Lesson learned. We immediately start the process to transfer all our workers from 1099 to W-2. It is a program, IRS has a program called Voluntary Reclassification, and it's a very good program. We were approved for that program, and it took for us few months, and we finished it. All our contractor become employee. I don't understand why another agency not follows the law. That IRS simply says the test of 20 numbers, it said, if people working hourly, you're paying them hourly, it's employee. If it's long-term relationship, it's employee, it's not contractors. It is a law. And they have, all of them has to follow the law. Only people who not follow the law, it's only because they want to have more profit. They saying we pay in unemployment, we pay in working compensation, but it is wrong. I get 1 minute. I get one more?
No, you don't get one more.
Sorry.
Good try. Tammy, please.
Good afternoon, Madam Chair and members of the Senate Finance Committee. My name is Tammy Bresnahan. I'm the Senior Director of Advocacy for AARP Maryland. I can't say it any more than everyone else has already said. We support Senate Bill 197, Residential Service Agencies Reimbursement. We thank Senator Ellis. You have my written testimony. I just want you to think about this. These folks are dealing with our most vulnerable populations. My sister had a stroke in late December. She's 73. And every day we worry because she's home alone. We run there after work, my nephews and I, but we don't know the people that are coming in there. There's 3 different people coming in, and you just want to make sure that they're not going to do something or that something's not going to happen to them. If something happens to them, they're covered because they have a covered employer. If something happens to my sister, they still have a covered employer. If, then she doesn't have to worry about her homeowner's insurance, having to pay out for someone getting injured on the job. These folks are our most vulnerable population, and they need to make sure that the people that are coming into their homes are covered employees. Thank you. And thank you, Senator Ellis. We support Senate Bill 197.
All right. Good afternoon, Madam Chair and members of the committee. My name is Allison Yunda, and I'm the Maryland lead organizer for the National Domestic Workers Alliance, otherwise known as NDWA. We are the leading voice for the estimated 2.2 million domestic workers who work as direct care workers, nannies, and house cleaners in private homes, providing essential care and supportive services. While we are a national organization, our DMV chapter is locally operated, membership-based organization covering the area of Washington, D.C., Maryland, and Virginia. Domestic and care workers comprise a growing workforce that has been historically excluded from basic workplace protections such as minimum wage, overtime, and anti-discrimination protections, health and safety, and the right to organize. NDWA has led the movement both at the federal and state level to pass legislation to eliminate these exclusions. Unfortunately, the rampant misclassification in the home care industry undermines these efforts and enables employers to evade the minimum wage, overtime, and other labor laws that home care workers have fought for. NDWA supports this bill to specifically protect direct care workers employed by agencies in the home care industry who are regularly misclassified as independent contractors and subsequently denied their critical workplace rights, including the right to overtime, earned sick leave, as well as coverage under workers' compensation and unemployment insurance. More than 750 residential service agencies or RSAs provide care for beneficiaries of Medicaid's home and community-based programs and are paid through public funds. Because of the structure of Maryland's Medicaid program, all personal care aides this bill covers are already employees under the law. This bill would prevent misclassification by providing that RSAs will only be reimbursed for in-home personal care under certain Medicaid programs if those who do the work are classified as employees. It is a simple solution to a serious problem. Maryland must ensure that residential service agencies receive public dollars, are abiding by tax and labor laws, and this measure would protect the direct care workforce from exploitation. Domestic and direct care workers have for too long been excluded from core workplace protections, which stem from the racist and sexist devaluing of household and caregiving work. For these reasons, NDWA fully supports SB 197, the Home Care Workers' Right Act of 2024.
Thank you, Chair Beidel and Chair Klossmeyer, and to members of the Senate Finance Committee. For the record, my name is Ryan Moran. I'm the Deputy Secretary of Healthcare Financing and the state's Medicaid Director, and I'm here on behalf of the Department of Health. I also want to thank you, Senator Ellis, for sponsoring this legislation. We have been working very closely with many of the people sitting here at the table and others on this particular bill. The department supports Senate Bill 197, which requires the department to reimburse a residential service agency for personal assistance services only when they are provided by an individual classified as an employee of an RSA. As is mentioned already, RSAs are agencies that are truly the backbone of Medicaid's long-term support services, and as well as our community care workforce across Maryland. As you've already heard, providing an array of services to Medicaid participants receiving long-term supports and services. Just for some context, there are approximately 920 Medicaid enrolled RSAs providing personal assistance services. And for some numbers in fiscal year 22, the department reimbursed RSAs $394 million in total funds for personal services, which approximately make up about 14,000 Medicaid participants. From the department's perspective of implementation and thinking about RSAs implementing this work from a Medicaid perspective, we would point out that the bill provides enough latitude for its implementation for Medicaid enrollment for those individuals by October the 1st, 2025, to ensure that they are fully staffed with an exclusively all employee-led model. So thank you again, members of the committee. And with that, we request a favorable report on Senate Bill 197.
Thank you to this panel. I have a question from Senator Reedy.
Thank you, Madam Chair. I guess first to the department, you mentioned 920 RSAs in Maryland at agencies, correct? So 920. How many of them currently that interface with your department, I'm sorry.
Right.
How many currently are W-2 versus 1099?
So we, in our written letter of support for this, we enroll these providers. The Office of Healthcare Quality, which falls within our Public Health Services Administration, license these providers, and OHCQ did a survey to RSAs to try to figure out what was the number of W-2s versus 1099. So that's included. What we found in that, not all Medicaid enrolled providers responded in that. I believe that there were 579 that responded to that
Pretty good
survey.
percentage, yeah.
And what we found was under 20% reported that they had 1099s as part of that. Specifically, if you want to get to the details in terms of the number of employees, there's about 12,000 plus. More than 10,000 of those employees were employees, and just under, or just north of, 2,000 were independent contractors. So a representative sample of that survey would say under 20% fall within consideration of what we're discussing today.
Was there anything in that survey that asked them to explain why they used that model?
I don't believe so, but I would need to look for the record, Senator.
Can I ask maybe someone else on the panel that is working in the industry? We have a problem with workforce. That's like a global statement. In the healthcare industry and in a lot of industries, we have a problem with workforce. So I know people who work in this space and in other similar home service type spaces that like the flexibility of being a 1099. Can someone who works for you, for instance, you said you're all W-2. Sorry to say you, I was trying to remember the name. But I have my list of names. Yeah, sorry. That's right. Gentlemen. What if an employee wants to work as a 1099? They can't work for you, correct?
Correct. That and under our model, and ultimately the Department of Labor has made that dictation with the requirements of the Medicaid program, the training, the oversight, the supervision. It fails the Department of Labor test for an independent contractor. And that is in the guidance document that was referenced by Matt at the state level as well as at the federal level. So correct, they would not be able to work for us in a Medicaid funded program under this regulation. This only applies to Medicaid funded programs, but for us in our agency across the board, we do not employ 1099 caregivers.
When you say that the Department of Labor made that distinction, the Federal Department of Labor makes that distinction,
Both.
you can't, both departments, well, they comply, so we comply with the feds. But,
Correct.
okay, so you can't. So, I mean, I guess my question would be, and maybe to you or to anybody
Sure.
else that's running these in the industry, my concern partly with this kind of thing is, in addition to, us dictating to businesses how they do things, obviously there's an ideological decision about that. But I understand this is Medicaid, so we can say, hey, we're giving you Medicaid, so we can have some say. I know all the arguments. Are we not perhaps causing a problem by not allowing more flexibility in cases where people want to be flexible? I imagine that if someone does not want to work as a 1099, there are other openings that are W-2 openings. As we've just heard, 80% of the ones that surveyed that are working with the state are all W-2. So why should we make a regulation to make everybody do this?
Yeah, if I could, that's a great question, Senator. 80% is the correct fraction of the people who self-reported, right? So half of the people, according to Mr. Moran, did not report, and I can probably guess why. The guidance document that was issued, there is a certification you've got to make that just says, I have read and will comply with this document. But that's another reason maybe why half the people responded to that survey. I think to your question, the labor law doesn't allow you to classify someone who does the same work different ways. So you can't have two caregivers and one inside a company as a 1099 and one as an employee. You've got to be consistent.
Because then there's not consistent.
Exactly.
I understand
Yes,
that.
sir.
Okay.
But there, as it relates to flexibility, we have caregivers that work for us as well as 2 or 3 other agencies. They can, really go to any agency they want. But with us, they would have to be an employee.
They have to be employee, but a lot of agencies will have pretty set hours, which does not allow you to set your time. Although I guess you're going to tell me that 1099s would work the same way.
They are, and that's one of the tests, right? If you control their schedule, they're an employee. Right. So if you tell them if you need to provide care for Mrs. Smith at 10 to 4, you're controlling their schedule, right? So that's one of the tests.
Final question, Madam Chair. Thank you so much for the latitude. Is there what you mentioned? We don't know why those people didn't answer the survey.
We don't.
We shouldn't.
We
get
don't.
aspersions.
That was speculation.
I'm assuming they might have been suspicious. Some of them may be a little suspicious of the intention of the survey, but it was. But we don't know. The if is there a concern also with profitability? And I asked maybe the department, this is more of a question. If we lose some of these providers because it's just not profitable for them if they have to use W-2, is that a concern?
Again, I think our perspective is that the timeline to come into compliance for an all employee exclusive model provides enough latitude to really rectify the issue of what's currently already codified as part of state and federal guidelines.
Okay, thank you. Thank you, Madam Chair.
If there are no other questions from the committee, I have a couple of questions. Ryan, it might be for you, but if someone is a 1099, that means that they don't have workman's compensation, correct? They don't have sick leave. And they don't have unemployment insurance.
That's right.
Right. So those are all things that I think we have worked, you know, as a legislator to try to make sure people are having the benefits that they deserve. So they have none of those benefits. They just get a straight check. They take it, they owe taxes on it. And when if they're injured, they don't have any coverage for workman's comp. So those are all benefits that they're missing. Can somebody here, I don't know if anyone was previously hiring as 1099s. Was that something we were doing in the state? We had 1099 employees for our Medicaid population?
Well, all of our, you know, we have providers that deliver these services. And so, you know, we don't directly employ those individuals at the state level. So these are all related to our Medicaid provider agreements. And I don't know if others want to.
So your provider agreement is with the company?
With the enrolled Medicaid providers. That's right.
And so then they hire people
the
that are actually,
individuals. That's
I just wondered what the rate is differently. Does the person really benefit by a higher hourly rate because they're not an employee because they are a 1099?
You mean from a Medicaid reimbursement perspective?
Well, just in general, you know, I mean, if they're an employee, 7.5% has to be paid by the employer for FICA and Social Security. So are they getting paid that much more as self-employed 1099? Do they get paid more, you think, than someone that's an employee? Can anybody, Matt?
Can I say something?
Matt?
You fight.
Can I go first?
Calling him out.
Yes, ma'am. All of the protections that you just listed there and a few more, they rack up to about a little over $2 an hour of cost to the employer, which would allow a 1099 agency to either pay more or make more. Yes, it's about $2 an hour.
So do you think that's happening? Are those folks making $17 an hour versus $15 an hour?
The $2 is either going to the employee or to the agency, one of the other.
Okay,
Yes.
thank you. Thank you for that
I want to
answer.
edit something.
I've
If
done-
after me, sorry.
We have
You
an
promise
answer.
me. You promise me?
We have a rule. We ask one question to one member, so we don't go
sorry.
down the line, but thank you. Do I have any other questions from the committee? No? Thank you, this panel. I think I might have two more people in favor, Lorraine Arikat, and is there, I'm a little confused. Is there a Wendy Wiley or did she speak earlier as Wendy Ura? Do I have a separate Wendy Wiley? No, that was you. Okay, I thought there was a name confusion. Lorraine, thank you.
Good afternoon, Chair Beidle and members of the Finance Committee. My name is Lorraine Arikat. I'm the Senior Policy Analyst with 1199 SEIU, United Healthcare Workers East. We are the largest healthcare workers union in the nation, representing 10,000 healthcare workers here in Maryland across hospitals and long-term care facilities. 1199 SEIU is a proud partner of the Caring Across Maryland Coalition, which consists of direct care workers, patients, loved ones, and advocates who are committed to improving the long-term care infrastructure in Maryland through bolstering job quality, protecting quality of care, and improving transparency and oversight of our long-term care industry. SB 197 ensures that Department of Health only reimburses the RSAs that are classifying their workers as employees. Often home care workers have no idea they're being cut out of the social safety net that employees receive and are struggling to pay bills, keep a roof over their heads, and it's simply unsustainable. Given the high demand of home care workers, this bill is an important solution to addressing retention of home care workers. 1199 represents healthcare workers across the care continuum, and we know how our broken long-term care infrastructure also impacts our total cost of care healthcare model and our already burdened emergency rooms. Ensuring that we have the care force in Maryland to let residents age safely in their homes will positively impact the entire care system. 1199 believes that care work is essential work
and that our public dollars should be going to law-abiding home care agencies, not those who undercut essential staff. And for those reasons and more, we urge a favorable report on SB 197. Thank you.
Thank you, Lorraine. Do I have any questions for Lorraine? Thank you very much for your testimony. I have Vicky Beard is favorable with amendment.
Good afternoon, Madam Chair, Vice Chair, members of the committee. I am a family caregiver. I have been for more than 20 years. I'm the last president of the Home Care Providers Union. I am also a CFC Advisory Committee member, and I'm here to talk to you about family caregivers. I'm going to read a little bit about what I think, and then I have a couple of questions or suggestions. The proposed bill banning the use of 1099 contractors presents some concerning issues for the CFC, CO, Medicaid reimbursed RSA companies. It would add an additional burden to the family live-in caregiver, who in my estimation outnumber all other caregivers in this state. Those that live where they work are expected to provide both formal and informal care hours, in other words, gratuitous care, free care, because according to Mark Leeds, and I quote, "We don't want to pay them for anything they might do for free." Show me where employees work for free. It seems that this is a mistake that could lead to much more caregiver shortages for our already underserved community. While there is a complete agreement that those that do not live where they work are W-2 employees providing personal assistance services, the same cannot be said for the live-in caregiver. IRS Notice 2014-7 makes it clear that the live-in caregiver's Medicaid payment for difficulty of care is not taxable. While there may be some gray areas as to FICA taxes, in most cases, if the caregiver is a spouse, grandparent, or parent, there is not in these situations. Even if a plan of service calls for 12 hours of care per day, that is the cutoff. There are 168 hours in a week, and many live-in caregivers provide all those hours. Much like the EVV exemption for living caregivers, could not the same apply here? Again, no argument. It's understood that this bill looks to create jobs and treat employees fairly. Absolutely, absolutely. But if a parent is caring for a severely disabled child 84 hours per week, this bill would send them out looking for a job or suggest that they go to another agency.
Will you wrap up, please?
Yes, then there'd be an overtime situation. So basically, I'm just here to say, HHS says this is a $470 billion industry. We need a partnership with family caregivers. They may not be a contractor, but they're not a W-2.
Thank you. Do I have any questions for this witness? I don't see any. Thank you for your testimony.
Thank you.
And now I have 5 unfavorables: Tyler Bennett, Nabila Adio, Alex Petrukov, Oluka Twayo, and Elizabeth Weglin.
Good afternoon, Madam Chair, Madam Vice Chair, members of the Finance Committee. I know it's been a very long day. I will be brief. For the record, Tyler Bennett on behalf of Circle of Friends, which is a residential services agency based in Ashton, Maryland. The president and managing partner, Alex Petukov, is also here today to offer some comments and answer questions as well. We're here in respectful opposition to SB 197. And I just wanted to highlight a couple things. SB 197 would require any RSA that participates in a state-funded home care program to classify all providers as employees of that RSA. In our clients' experience, many caregivers prefer the flexibility that comes with being a 1099 contractor. They like to choose their clients, choose where they work, choose when they work. Many of them are part-time and many work full-time jobs elsewhere as well, or act as 1099 contractors for multiple agencies. We understand that there are providers out there that who have caregivers coming to them because they prefer the W-2 model. But if this bill should pass, it would eliminate the flexibility for those that don't. We're already experiencing a shortage of caregivers in the state, as been stated many times before. And if RSAs that currently utilize that 1099 model have to pivot to W-2, many of the RSAs, particularly the ones that are the small businesses, could cut hourly pay, hours, or could potentially shut their doors altogether. As we know, Medicaid reimbursement rates have lagged behind increases in the cost of doing business, and mandating a change to a W-2 model would further that discrepancy. We also believe that such a change could push self-employed providers that prefer that greater flexibility to seek private pay clients or clients with long-term care insurance, which could exacerbate the shortage of the caregivers that are serving the Medicaid population. So thank you for your time. I know I only have a few seconds left, and happy to answer any questions or direct you to Mr. Pachukov, that might be able to drill down a little deeper.
Thank you. My name is Alex Patukov. I'm the managing partner of Circle of Friends in RSA in Maryland. Thank you, Chair Vital, for giving us opportunity to speak this evening, Madam Vice Chair, and all the members of the Senate Committee. We appreciate your opportunity to try and look out for the seniors in our community. Senator Ellis, thank you for this bill. I understand you are definitely a proponent of good health care in the state of Maryland, and we appreciate that. No, we just disagree slightly on the best way to go about it. No, we believe this bill is dangerous for the caregiver community in Maryland. You know, as you could see in my written testimony, there are hundreds of RSAs in Maryland, and there was a study that was requested by the House delegates and the Senate a few years ago to do a study of the payments that are currently being paid to the RSAs. That study concluded that the RSAs are dramatically underfunded. Now, that is one of our biggest fears of this kind of a conversion, is that hundreds of smaller RSAs will not be able to successfully navigate this transition. It is a costly transition. And the biggest fear that we have is neighboring states such as Virginia and DC have a much higher reimbursement rate. If we were to do this, lots of caregivers will simply go to the neighboring states, making the caregiver shortages even more. As well as many of the caregivers that work for us enjoy the flexibility that comes with being a 1099 contractor. So lastly, I will say that this bill does not solve the misclassification issue. This will only solve it in one small area of home care in the Medicaid space. If you wanted to solve the misclassification issue, pass a bill that just perhaps supports some of the laws that are already on the books. Agency like us has been audited many times and have passed every single audit. So there's plenty of agencies that do it legally by the books. Thank you for your time.
Good afternoon, everybody. Good afternoon, the chair and honorable senators. My name is Olukayode Taiwo. I'm a registered nurse and I'm a provider in the community. I strongly oppose this bill because as a provider in the community, it's going to shut our business down. It's going to shut other businesses down. I call this bill a killer's bill to my colleagues. And at the same time, it's going to kill passionate caregivers like me and other people in the community. Because of my passion, I rise my way up from being a nursing assistant in a nursing home. I became a licensed practical nurse, registered nurse, and I have 2 masters, and I run 4 nursing homes. I know about reimbursement, and I know very well the reimbursement is very low. When I become a provider in the community, I realized that it's not easy to hire because many people that come to our agency want higher pay, and we are ready to give it to them whenever they ask for higher pay. But we cannot. A lot of them have 9, 10 patients in the nursing home. They come to our facility, they want just 1 patient, and they want so much money to be paid to them. It's not physically possible for us not to have 1099. And we give them the option that, listen, we cannot hire you and pay this higher pay. And they decided to go to other states that will pay them more money. So by not having that flexibility of being able to hire, this bill is going to promote or encourage monopoly and reward the greed, discriminate against a lot of people, like businesses and then shut a lot of people down. And again, it's gonna definitely take the rights of a lot of people away and the right of a lot of businesses to be able to negotiate. Thank you. You have any question for me?
Hello, my name is Nabila Adio. I'm a 1099 caregiver. Now, most of the clients I service need minimal care. We focus mainly on personal care and tasks of daily living, such as getting dressed, grocery shopping, but most importantly, a caring heart and companionship. Now, when you're restricted between 9 and 5 or whatever hours are given to you as a W-2 worker, you really don't have that flexibility. I also have a family to take care of. I have grandchildren, I have children, and being a 1099 worker gives me the flexibility to take care of them, take them to school, bring them back, and still work. I also have the ability to choose my clients, who I work for, my location, my pay, rather than be told where to go for and for what reimbursement. And I have the ability for tax write-offs. All these things are really important. So I'm actually looking for flexible companies that use the 1099 contractor model. It is also important to note that the companies I work for discuss this 1099 worker class with me before the start of a new case. So it's not that I'm deceived into a 1099 situation. We're also covered, well, my company also covers workman's compensation, and I feel respected, cared for, and valued. I have occasions where I'm not happy with certain clients, and I have I have changed my clients with open dialogue. In closing, I request that you do not pass this bill. Thank you.
Good afternoon, Madam Chair, Elizabeth Wagline. And thank you to the Senate Finance Committee for entertaining the testimony. I represent the Elizabeth Cooney Care Network. We're a 67-year-old home care agency. We're the oldest in the state, actually oldest in the United States, full service. We provide unique caregiving throughout Maryland. So we represent all the different counties. So we are in your backyard. Medicaid in particular is the lowest payer system within the state. You heard testimony saying the fact that all the other programs are allowing independent contractors and employees. So you have a bifurcation in those programs, but you're taking the most vulnerable citizens and then narrowing the workplace scope for having available caregivers. So we're at a crisis. You heard the first bill today from 2 secretaries saying we need innovation. We need more choice. We need more accessibility to be able to care for our aging population. Independent contractors do understand, and as you just heard, agencies are transparent. There is guidance that was just passed from the Maryland legislature to allow independent contractors and exactly how they do it. Independent contractors understand they have the ability to actually pay their taxes on apps. They're able to pay into unemployment, workers' compensation, and their professional liability. So indeed, they would be protected not only for themselves, but for the clients that they actually care for. I also sit on the Maryland, I'm a member of the Maryland National Capital Home Care Association. I also sit on the Community Options Committee Advisory that oversees this. We're in the midst of change to actually allow more diversity because there are not enough caregivers, to allow self-directed care with FMS. So we need to have as many options at the table as possible. So I'm urging an unfavorable report. Thank you.
Thank you to this panel. I have a couple questions. Senator Ellis, I saw your light first.
Yeah, thank you, Madam Chair. And, thank you for being here and for basically your hard work and in a really tough industry, and I understand that. Being a CPA in many years, I've dealt with a lot of individuals. I mean, not just in your industry, but in all industries, with this issues, whether an individual is an independent contractor or call it 1099 employee. That's a form that must be given if someone is an independent employee. Form 1099 is an IRS form 1099, or versus an employee. And the IRS have strict guidelines about who is classified as an employee versus a independent contractor. And there have been a lot of court cases in recent years, Uber drivers like in California, others, and I'm sure you're aware of the results of those cases where, they're labeled as employees, right? And so the IRS have the general guideline. I'm just looking up here from the IRS. The general rule is that individuals is an independent contractor, the payer, that means like your company who pays these people who provide your service. If the payer has the right to control or direct only the result of the work and not what will be done and how it will be done. So if someone is going into a home to take care of someone, if they require 24/7 care, for instance, and they have an 8-hour shift, so that's 3 times 8 is 24. So that's 3 people, right? 24 hours. Can they show up anytime they feel like, or there are certain times each one of those 3 have to show up? Can they just show up anytime they feel like and stay however long they want and say, well, I got that work done in 10 minutes, I'm out of here, and get paid the same? Is that possible?
Can I answer?
Anybody, yeah, sure.
So what generally happens is that you agree with the patient or the person responsible for the patient, the times you get there, and not necessarily the times you leave, but at least the times you get there, and making sure that the amount of work you need to do is you put in that amount of work. So if you decide you want to get there at 13 minutes past 2, then you get there at 13 minutes past 2. It's not necessarily 8 hours. It depends on how complex the work is.
Right.
Yeah.
So my scenario is can all 3 of those people show up at the same time if it just happened that way?
No.
No. So the time is determined by
yourself
and the agency, right?
Exactly.
To coordinate.
Yes.
Continue.
The agency coordinates.
Yeah.
But you agree with the client.
Yeah, sure.
Right?
Yeah, so
Senator Ellis, if I could just jump in. So in this Medicaid program, Community First Choice is actually kind of controlled by the state of Maryland. So if anybody has control in the situation, it's more of the state of Maryland and the caseworker that takes care of this client rather than the agency. The agency is an intermediary between the state of Maryland and the client. We as the agency don't tell the caregivers to come at 4 o'clock. They figure that out between them and the family and the caseworker.
yeah, but it's figured out and the time is set.
Correct, but there's less control of the agency. The agency does not have control of the caregiver.
Right. And so the
So
general rule
it's
is
not a white or black test. It's
Yeah.
really gray, and that's why we're able to beat a lot of these audits because it's not really our control.
so you can beat it, huh?
Favorable is the term
Okay.
here.
Well, I mean, and so I understand. So I understand. So basically, there's somebody in the entire, I'm a military guy, chain of command who coordinate this. And so folks who just can't show up at the same time, do
It's
whatever.
not us though.
But whoever it is, so
Yes, sir.
so that
Absolutely.
test from IRS says so they're controlled by somebody, and so that's the issue right there. Deal with a lot of different industries, and that's what you're up against. So I just want to just bring that up, and thank you, Madam Chair.
Thank you, Senator Reedy.
Thank you very much, Madam Chair. So the question I think on the end here is, in your experience, are there workers that you ever hire that can't read?
No, they have to be able to read English.
And they can,
First of all, they're typically are certified nursing assistants. I actually started the certified nursing assistant program in 1996 through legislation, sat as its chair for 28 years, developed the education, regulatory and disciplinary. And that means they have to actually read to be able to go through that training, clinical, and then certification.
and then also are they confined to, they can only work for you, or can they go work for other agencies?
No, the whole premise of an independent contractor is they have the ability to work for whoever they choose. We have, there are in the marketplace that most independent contractors work for multiple companies and also on their own.
Yeah, so it stands
they
to-
may be on care.com. They may be with multiple agencies and they will pick and choose who, where, and when they would choose to work.
So it stands to reason that these folks are of course very important to our healthcare system, and they're capable of making decisions for their own economic benefit without necessarily being told that they, that being a W-2 or being 1099 is bad. Now, maybe some folks can get confused from time to time, but generally people are usually able to make their own economic decisions, you think?
I do believe that, and I think you've just heard testimony from my colleague here to my left that indeed there are options, and within the marketplace, you heard Ryan talk about the 80-20, so they're 80% of W-2s, 20% of independent contractors. That marketplace was developed by choice.
Thank you very much. Thank you, Madam Chair.
Thank you. I have a question for Alex. So we had home care for my dad for 5 years. And if somebody didn't show up on time, we would call the agency and the agency would either find a replacement or find out what was going on. What do you do when one of your workers doesn't show up on time?
Sure, it's a good question. So in the agency has a wait list of caregivers that are looking to be matched with a client. So at that point, we can provide the list to the client to have another caregiver come in and take over.
So you do get involved and control that when someone doesn't.
Yeah, we
show up.
provide screened caregivers that are tested, references, criminal background checks that have gone through CNA school, that come to us well-trained and educated on what they do. And at that point, we match them up with a participant that's ready to go.
So your company writes the check for the hours that the person has worked?
So the way the system works is the caregiver goes in and works. The state of Maryland pays for that caregiver's services to the agency, then the agency pays the caregiver. So it's not.
Thank you.
Yep.
I have one virtual, Christopher Meyer, is he on? Christopher, thank you.
Thank you, Chair Beidel and members of the committee. My name is Christopher Meyer. I'm a research analyst at the Maryland Center on Economic Policy. We support Senate Bill 197 because it would guarantee bedrock protections to home care workers and strengthen the workforce in the long run by making sure that these are high quality jobs that are attractive to people to join and then stay in the industry. I want to make very clear what Senate Bill 197 would not do. The bill does not preclude flexible work arrangements. They're all different kinds of scheduling arrangements that employers and employees in the ordinary bog standard W-2 model can make. That kind of flexibility would absolutely be continued to be fine under Senate Bill 197. But what this bill does do is make sure that employers are not able to get out of their responsibilities to follow labor law protections, as well as to shift their payroll tax responsibilities onto workers. So to quantify the effects of that tax shifting, in 2022, according to the Bureau of Labor Statistics, a home care worker in Maryland typically took home about $15.26 an hour. But for a misclassified worker at that hourly rate, because of that tax shifting, they're actually taking home the equivalent of only $14 an hour. And as was discussed on Tuesday during a bill related to data, we just simply, the state doesn't know if maybe misclassified workers are getting higher wages. But there's no reason to believe that that is the case. Misclassification also increases pressure on the state budget. Home care workers are care experts, they're not tax experts. When I'm feeling generous, I might characterize myself as a tax expert, but I'm definitely grateful that payroll handles withholding for me. misclassified workers aren't so fortunate. So Senate Bill 197 would put tax administration back into the hands of trained professionals and stanch one potential source of revenue loss. Because of those tax and work protection reasons, and it would strengthen the workforce, I'm asking for a favorable report. Thank you.
Mr. Burke, do I have any questions? No questions. So that ends the hearing on Senate Bill 197. And our last bill of the day is Senate Bill 98, Department of Housing and Community Development, Food Desert Study, and we have Senator Stallings, Chief of Staff, I believe, here to present. Hi. And we can also bring up Carla Schroyer and Kelly Locklear. You can begin.
Thank you. Oh, oops. Is it on? Do I have to press a button? Okay, we're good. Thank you to the chair, vice chair, and members of the Finance Committee to allow me to speak on Senate Bill 98 today. For the record, I am Danielle Coyle, and I am presenting this bill on behalf of Senator Salling today. Food deserts have begun to increase in our state. Last year, a grocery store in a central community in Baltimore County closed down, which concerned many residents. The last food desert study that was conducted in Maryland was roughly a decade ago. This bill will require the Department of Housing and Community Development to conduct another study and make recommendations to to reduce food deserts across the state. Food desert studies help identify where residents have limited access to affordable and nutritious food, highlighting vulnerable communities that may be at risk for food insecurity. Understanding food deserts is crucial for assessing the health implications on residents and promote social equity by addressing disparities in access to healthy food options. Food desert studies can shed light on economic opportunities, such as the potential for new businesses and business initiatives to address the lack of food access. Findings from food desert studies can inform educational initiatives aimed at promoting healthy eating habits and nutritional awareness. Policymakers can use data from food desert studies to develop targeted policies that incentivize the establishment of grocery stores in underserved areas and improve overall food accessibility. Studies have also shown that improving access to healthy food options in certain areas can contribute to crime reduction. Food desert studies may guide initiatives aimed at enhancing community safety through increased food access. And conducting food desert studies raises public awareness about the importance of equitable food distribution. It encourages dialogue on the systemic issues contributing to food deserts and mobilizes support for positive change. I want to thank you for allowing me to speak here today on behalf of Senator Salling, and I would ask for a favorable report on this bill.
Thank you very much. Go ahead.
Thank you, Madam Chair, Madam Vice Chair, and committee members for the opportunity to be here today and provide testimony. My name is Carla Schroyer, and I am the Director of Community Choice Pantry Services at Community Assistance Network. Community Assistance Network, or CAN, is the designated anti-poverty organization serving all of Baltimore County, Maryland. We are part of a network of over 1,000 community action agencies and one of 17 in Maryland. CAN provides programs to address food, housing, and income security, as well as promote self-sufficiency. CAN is in support of Senate Bill 98, which calls for the Department of Housing and Community Development to conduct a food desert study to analyze the location of food deserts in the state, make recommendations to reduce the number of food deserts in the state, and determine the impact of food deserts on the local population and economy. As Director of Community Choice Pantry Services, I see the impact that food insecurity has on the neighbors that we serve, as evidenced in the neighbor impact statements I included in my written testimony. Based on my daily interaction with Baltimore County neighbors, feedback from partner agencies, and calls received indicating a need for pantry service, we know that there are countless other constituents with barriers to food access, such as lack of transportation, lack of funds needed to travel to agencies like CAN, grocery stores, or drugstores. As well, the absence of grocery stores, drugstores, and community-based organizations in these food deserts. Conducting a food desert study will empower communities to make lasting changes. Based on positive improvements that CAN has made to our facility and our food access policies, I have several recommendations. Provide access to healthy, nutritious food and medicine in communities where those resources are lacking. Over time, we will observe improved physical health of the community members. Provide community members with the dignity of choice so that they are afforded the opportunity to feel a sense of ownership and pride in their community. Over time, I submit to you that in neighborhoods where these changes are made, we will observe improved mental health and a decline in crime. It will also empower agencies like CAN to best serve the constituents.
Can you wrap up, please? Thank you.
Yes, I ask for your favorable response. Thank you.
Kelly, you are our last witness. Oh,
I'll
no,
be
I have a
brief, I
virtual. after
promise.
you. You're our last in-person
So
witness.
you have a
today.
voting session. So, Madam Chair, Madam Vice Chair, honorable members of the committee, for the record, Kaylee Locklear here on behalf of the Maryland Retailers Alliance. We also represent the Chain Drug Store Association for the state. Over the years, I've heard from different localities across the state. I've also heard from different members of this committee concerned both about retaining their food retailers and pharmacies, as well as expanding them in communities. So we do think that this is an important study. I did want to mention to you that New Jersey is leading the way across the country in this front. They conducted a similar analysis, and then they created their food desert program that I just wanted to touch on really quickly. They've ultimately decided that they're going to be providing, and I know it's touchy right now, $40 million a year in tax credits, loans, grants, and other technical assistance to increase access to nutritious foods across our state, and then develop new approaches to alleviate these concerns. I did just want to point out in the bill, it's not explicit that the department should look at maybe other states or localities that have come up with solutions here. So that might be something important to add to the study that would help, I think, alleviate some of the concerns. So with those comments in mind, we urge a favorable report. Glad to answer any questions.
I don't seem to have any questions, and my virtual witness is not in. So you are the last for the day, just before our voting session. So thank you. Oh, Senator Hayes does have a question.
Thank you, Madam Chair. What is the end goal for this bill? Right. Kaylee gonna let
Do you want me
borrow
to?
the mic.
Oh,
She'll let
sorry.
you borrow.
I would ask that you refer any questions that you have to Senator Salling directly.
All right, so I got you. So there is plenty of information out about food deserts, right? There's also established here in the state of Maryland and the Interagency Food Desert Advisory Committee, which is various different agencies made up of DACD. The bill itself only asks the Maryland Department of Housing and Community Development to look at it. And the only contribution that that department has is pretty much providing a subsidy to businesses. And so my question is the goal to really address food deserts and all of the, other things that's attached to it? Or is the end goal to get pretty much a greater subsidy for businesses? Because it doesn't actually apply to the actual, the interagency group that's charged with this. This group has actually been formed in state law to advise and make recommendations to the department on the development and adoption of regulations related to food desert projects, make recommendations to the secretary on applications of designating an area as a food desert, and make recommendations of an interagency coordination to reduce the number of food deserts and promote healthy food access. And so there's already an opportunity for this to take place on an interagency level, whereas you have the coordination of several different agencies. And so I'm not sure if the bill as drafted is getting to what you all entail in getting rid of food deserts.
So if I may, I think there is a combination of solutions that need to happen when you're looking at solving and reducing the number of food deserts that are in communities. So if I may, I think that that's probably one of the reasons that they're trying to do this. If there is a better way to I don't know, involve all of these different groups. I wasn't even aware of that group, Senator Hayes. So to coordinate information to produce a study, I think that that would make sense. And like I mentioned, New Jersey took a lot of information, both from localities and then looked at it from a state level to come up with solutions. And they weren't just subsidies to businesses. There were a variety of recommendations that they made to go ahead and reduce those food deserts.
Right. No, and I totally understand. That's why the bill is drafted concerns me, because the only role that DACD plays is for their Business Works program provider subsidy.
Sure.
Right. The other agencies have a more in-depth looking at all of the disadvantages that communities that have food deserts have. And so, it's been created in state law to serve this purpose. So I would say if we were to proceed with this, it would make more sense to charge the coordinated agencies with the task that's assigned, as opposed to just having DACD. And the timeline is very short, probably for that purpose, because they're singular in their focus on the issue.
I would defer to the sponsor.
Thank you, Madam Chair.
Thank you to this panel, and that ends our hearings for today. Committee, please stay tuned as our committee manager switches over to our voting session. We just need a couple of minutes and we'll be voting. Thank you.
Yeah.